All right, very good. Well, I hope everybody had a good night's sleep and enjoyed watching a little late basketball. And if you can't hear me, let me know. And we had a lot of feedback yesterday. We'll use the mics for questions in the room when we have some panel discussions so you can hear everything. So thanks for that. Again, thanks to the payers for being willing to sit on the panel. I think some of them are back. Some of them aren't, mysteriously disappeared, probably never to return to Greensboro. And thanks to our sponsors again for helping us make this happen. It helps us with the room and the food and so forth, so we really appreciate that. And again, we don't just invite any vendor, we invite vendors that we think have some value in the outpatient joint space, so thanks to them. Somebody asked me a question about why this hotel was called the Proximity, and was it just because we're in close proximity to our surgical center, and that is not the answer. It's convenient, but we don't get that kind of influence with Dennis Quaintance. So denim was invented in Greensboro, believe it or not. So Levi's and Wranglers, all that stuff started here, and they had two plants. One was called Proximity, and the other was called Printworks. And so this is the Proximity Hotel, and it's the Printworks. 80% or 100% of all the fabric in the room and the carpets are local. All the artwork is local as well. So Quaintance and Weaver they're neat guys, and they do some pretty cool stuff. But it's a very green hotel, very local. But that's where Proximity came from. Interesting stuff. Feedback. There's little cards on your table with the Proximity Hotel and a pencil or pen or something. So we're going to do this same time and place next year. We will plan next year's event as soon as we're done today. And one of the things we'll do next year, last year we knew we were going to do a payer panel. One of the things I know we're going to do next year is a case management track. So we'll get the Revolution room, which is just down the hall. You can bring your case managers, and we'll have seasoned case managers, most of which are here, and just an exchange of information and ideas and helping each other on different things they can do to help you run a cost-effective bundle. So we'll get you that information, but we'll have a case management track for sure. I'm not sure what we'll do with the payers, but I'm going to try to get them all back. I still don't see all of them here. Try to get them all back. And then yesterday we did our first round of speed dating with payers. Downstairs in the lower lobby, Donna and Rebecca had Blue Cross with Kreutzer, and then Cigna with Zarza, and Dr. King with Aetna. It was really pretty interesting just to look around the room and see the potential of bending the healthcare curve. It was really impressive. So next year we're going to do that a little bit more formally. So we'll get you that information and plug you in and make sure that we're trying to get the payer and the providers together. I've got a Journal of Arthroplasty. Can you hand that to me, Joe? Magazine there. This is our journal from the American Hip and Knee Society, and I was reading yesterday, just as a parlay into our discussion this morning, and there was an article in this month about patient perceptions of the safety of outpatient knee arthroplasty. And they asked a whole bunch of patients who had inpatient knee replacements, what is your thought on having this done as an outpatient? Well, no shocker, 70% of the patients said they didn't think they'd be able to do it. And so we as physicians and case managers for sure know why that is. It's because they received no education. No one told them you could go home the day of surgery. No one educated them on how that would be possible. And so the reason I bring that up this morning is because we're about to talk about clinical pillars. It's absolutely possible to do in the outpatient venue. Dr. King's done hundreds. Many of you have done a lot. We've done 359 outpatient bundles. So it's very possible, but the patient perception has to be changed. So we're entering into a clinical pillars discussion where it's our job to learn these things and then educate your patients. And it's the physician, it's that first when you say, yes, Dr. Lucy, I'm going to have my knee replaced. It starts with me saying, well, we're going to do it in an outpatient center. You're going to do great. Do you have anyone at home? Blah, 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 blah. What's your insurance? You're the captain of the ship. You start the conversation. You hand the ball off to your case manager and your PA, and then it's an education piece. So we have a beautiful education video for Delta that we spent money on that takes them through the whole thing. So we'll talk a little bit about those things. So first up on the clinical pillars is Dr. Rowan. So how we're going to roll this morning is we'll talk pre-op, peri-op, post-op. Then we'll talk about case management. We'll give a little clinical report on our first 350 bundles, and then we'll have a panel discussion. So if there's a burning question, go ahead and ask it to the person at the podium. Otherwise, I'll bring them back up, set them down, and we'll have a little Q&A. Okay?
Good morning. Talk a little bit about getting your patients identified and ready for surgery here. Okay. Preoperative things to consider. First thing you want to do is identify the correct patient for this type of surgery. You also need to make sure you've got the correct surgeon for this type of surgery. There's some things you need to consider in scheduling to get them ready. You have to do this a few weeks out. Case management is critical. The care plan is given to the patient very early so they know what to expect, and managing expectations is a big deal. And then hoteling, if you're going to have people coming from a 3 to 4 hour drive away, which is pretty much where we've set it for our entity. Let's see. Safety. That's what the patients are really concerned about. What was it? A few months ago, 60 Minutes had one of their little scare shows on how bad outpatient surgery can be, but it's simply not true. If you set up the proper program with the proper surgeons and preparation, this is a very safe procedure. Most of us in this room have been doing outpatient joints for 5 or 10 years anyway. You're just sending your patients home after 23 hours from the inpatient facility. We've had a lot of practice at this. When you're dealing with an ASC, there are certain things you have to keep in mind. In North Carolina, you've got 24 hours to play with. In some states, you've only got the day of surgery. You can't transfuse people. You have to be aware of any sort of complications related to patient motivation. People are on opioids. You probably shouldn't be doing them at an ASC. As far as how do you identify these people? The traditional system, the anesthesia system is a very poor predictor of who's going to stay for 23 hours and who's going to stay for 2 or 3 days. There's studies showing that. When you're setting up your program, there's a lot of articles, Journal of Arthroplasty over the last few years, Meningini's aura criteria, Court's written some articles. Most of us who've done a lot of these, you can look at somebody and look at their numbers and say, yeah, you're an outpatient or you're not. Let's see. Okay. Just looking at the patient, they've got to want to do this. If the patient's if you talk to them for 5 minutes and they're just scared of doing this as an outpatient, you might want to reconsider it. They have to have somebody who's willing to stay with them for 2 to 3 days, and they need to be healthy. One lady I talked to this about said, oh yeah, my husband will help me. And about 5 minutes later, he cruises into the exam room in a wheelchair on oxygen. No, he's not. He's not going to help you. It doesn't work that way. Absolute exclusions. Hemoglobin is less than 10. This is our program. BMI is over 40. That's kind of getting to be the national trend. A1C is over 7.5. Opioids, our rule is over 10 milligram equivalents of oxycodone a day. And I can't emphasize that one enough. You put somebody on pain management in the ASC, you're just asking for trouble. They're the ones who won't go home. Relative exclusions, after the first year, we started doing people with a little more risk. Sleep apnea, coronary artery disease that's been managed and is asymptomatic. History of a DVT, again, that's been managed, and they're probably off of their Eliquis and warfarin. Those are people that we're doing now with pretty much no issues, no problems. And then you have to keep in mind your ASC capabilities, your home health availability if you're going to use it, and again, local laws, 23 hours versus 1 day. As Steve mentioned, the old ASC we had, the air handlers in there really weren't set up to snuff for doing total joints. When they built the one here in Greensboro, we were supposed to open in, June? And it got delayed till September because one of the ducts was like an inch and a half off as far as the airflows that was required to positively pressurize the room. The operating rooms you use in your ASC should be every bit as good as your inpatient facility, if not better. For the surgeon, we settled on 75 hips or knees a year. That's if you're not doing them on a regular basis, you probably shouldn't do them at the ASC. For shoulders, our shoulder surgeons decided 50 would be appropriate. You need to be able to do these cases in a reasonable period of time, an hour and a half or less skin to skin. Minimal blood loss, again, going back to the fact that you can't transfuse these people. And then, again, practice at the inpatient facility. Get used to sending people home in one day. Your length of stay over the last few years, if it's probably 2 days or less, you're in pretty good shape. And then, of course, you want to look at infections and complication rates. The way Delta was set up, 4 fellowship-trained people got together and set up the company and set up a board. Ideally, whatever entity you set up, you should have some governance, hopefully by fellowship-trained arthroplasty surgeons. And then the other thing is you actually have to enforce this stuff. In our 4-man group, that's kind of fallen on Steve and me, and occasionally you got to say no to one of your partners. No, that patient's got AFib with an arrhythmia and they're on warfarin. We really don't want to do them at the ASC because people will tend to push the envelope, or at least try. Scheduling, as with all total joints, inpatient or outpatient, you need a few weeks to get these people ready. It's not like they're going to walk in and you're going to, you can scope their knee in one day, but as far as setting them up for an arthroplasty, most of them need clearance. They all need some blood work. Some people will need an EKG or a chest x-ray. You need at least 2 weeks lead time to set these people up. You want to have time to reserve your time at the ASC. The labs we get, everybody gets a CBC, BMED, PT, INR. Pretty much everyone's getting a spinal now, and if you're going to do spinals, anesthesia is going to want the PT and the INR. And again, you want to get clearances from their PCP for any medical problem they have. After they've gotten their blood work, then you set them up with the case manager who's going to also review their labs. They're going to go over a set of questions that we've baked into our software to make sure that it is safe to have it done. So when you and the patient decide to have the surgery, that's your first screen. The second screen occurs with the case manager, and it can be quite valuable. It's amazing how many people, the second time they go through a detailed set of questions, will say, oh yeah, I forgot to tell you, I had a PE 2 years ago. That's important stuff you need to know. All right. And our hospital, an ASC, the H&P has to be within 30 days of surgery, so there's also that to schedule. Our ASC contacts the patient, sets up the anesthesia, talks to them about the facility, often gives them a tour, and answers all the financial questions. The one thing about a prospective bundle, the copay, deductible, or down payment is paid up front. And it's nice if your ASC has something like care credit, which can spread it out over a 12-month period of time. In the last, since we set this up, I think I've had 2 patients who could meet the financial requirements to have it, get the money paid up front. But then again, that's their only one bill. They don't get bills afterwards. So it's still a big benefit to the patient. Case management, this is critical. You need to hire the right person. It needs to be a nurse who's done this, preferably for BPCI traditional or BPCI-A. They're going to get the patient enrolled in the software. They're going to collect the patient-reported outcome measures, which are very important for the payers and CMS. They're also going to, before the surgery ever occurs, they're going to know where their physical therapy is going to be, where their DME is coming from. They're going to get phone numbers. The case managers talk to them before and after surgery, and it's very important. It's a concierge experience, and the patients love it. I'm going to get ahead of myself. Let's see. Yeah, so that was pretty much the whole thing right there. You guys have changed these slides a little bit. This is the actual care plan that's given on the first interview. It's got all the demographics in it. It's got the surgery center, the times to show up, who the surgeon is, the physician assistant, their physical therapy provider, their DME provider, follow-up appointment with the surgeon already scheduled. So this occurs probably at least a few weeks before surgery. The patient gets that, it's in their hands, and it's a great reference. The other thing that's very important is telling the patients that if you have a problem, call us first. Do not go to the emergency room. Really, the only reason to go to the emergency room is probably shortness of breath or chest pain. Everything else we need to hear about. If it's the wound, talk to us, because the ER is just going to make you wait 5 hours. They're going to look at the wound and then call us and charge $1,000 to do that, which will kind of screw up your bundle. And it's bad for the patient because the patient has to wait for 5 hours. They're not happy. Let's see. And then hoteling, it's nice to have a relationship with a nearby facility. It should be in close proximity. Steve stole my thunder on that one. We even put it on the building. But we have an agreement with proximity. They will give a bit of a discount. They'll house patients before and after surgery if they need to from out of town. They have transportation. I don't know how often you use that. They have a little British cars right there that are kind of cute. And it kind of completes the concierge experience. And that's it for the pre-op. Any questions? Brent? Okay.
All right. So now I'm going to speak about peri-op, the day of surgery. So we're going to speak about standardized order sets, the anesthesia, pain management, OR efficiencies, therapy, and then the recovery care unit. So in perioperative management, the whole key to success in this, is standardization. Your margins are very tight. You have to prevent complications. And the way to prevent complications is to prevent leakage. And the way to prevent leakage is to have every single thing standardized. So from pre-op order sets to the way we treat the patients through the day of surgery to everything post-op, it is all standardized. So order sets, again, pre and post-op orders are standardized. Now the orders, everything we've come up with is based on best practices with our experience with one-day hospital and then what we've gathered from our friends that have been doing this for years in the outpatient realm. And we make revisions based on observations we make and feedback we get from the patients, from our partners at the hospital, at the surgical center, and from our case managers. So anesthesia is also standardized. On the hips, they all get their adjunctive medications in the holding area. They get spinal anesthesia for the procedure. The knees, for the unis and total knees, will get their adjunctive meds in the holding area. We'll get an adductor canal block in the holding area, and then the spinal in the operating room. They will also get an intra-articular block during the case. We either use Exparel or other cocktails for the intra-articular block. For OR efficiencies at the surgical center, we have dedicated orthopedic teams. We have nurses that are now very experienced and surgical techs that are very experienced in these procedures. X-ray techs have gained a lot of experience doing the total hips. They've gotten much more efficient with that because we're all doing them anterior on the HANA bed, so we're using C-arm for that. They've gotten much better with it. The surgical center will provide a second assist, and we all have experienced PAs that have been doing this in the hospital with us for years as our first assist. One of the important things at a surgical center is sterilization costs. So we've partnered with the implant companies to trim down the instrument trays. This leads to a lot less expense and easier turnover if we're doing multiple cases. And the companies around here all have experienced implant reps that have been working with us in the hospital setting for a while, and that's also very helpful. Pain management, we use a multimodal pain management strategy, and guess what? That's standardized also. Preoperative holding area, they're getting their adjunctive medications, Celebrex, Tylenol. Usually it's given intravenously. It's either given PO or in holding or intravenously in the operating room. And we're using gabapentin adjunctively, which has been a huge benefit for decreasing the opioids post-operatively, especially with the knees. The knees are also getting the adductor canal block. They get a preoperative nausea and vomiting assessment from anesthesia. They all get Zofran. They may get additional things such as a scopolamine patch if they've had problems with nausea and vomiting in the past. Intraoperatively, they're all getting a spinal anesthetic, the IV Tylenol, Decadron to decrease nausea also, Zofran. The hips are getting just subcutaneous Marcaine injections, and there's the intra-articular knee block, either with the Exparel or other cocktails. That's the only thing that's not fully standardized. That's more surgeon choice. But they are all getting intra-articular blocks. Post-operatively, for pain, the opioid analgesics, we're really cutting way back on the use of those. Tramadol, Celebrex, Neurontin, Tylenol. They're getting Zofran or Phenergan for nausea. Blood management, and it's key. You have to minimize blood loss for successful ambulatory surgery. You can't transfuse them at a surgical center. So this is done by technical competence and efficiency. Hypotensive spinal to decrease blood loss during the case. Transexamic acid, all the patients are getting transexamic acid. The first case of the day, they'll get it IV. The second or third case of the day, they'll get it PO. Doesn't matter what you do. You can sprinkle it in the air. All you have to do is order it, and their blood loss is decreased. It's the best medication we've ever seen for that. So they'll get a pre-op, and they also get one post-operative dose. Fluid management, absolutely essential for a successful transition to outpatient arthroplasty. The patients are going to be prone to orthostasis, especially the first time they get up with their early mobilization. So they'll get fluid boluses before they leave the operating room, before they leave the post-operative acute area, and when they get down to the overnight area if they're staying overnight. The problem with it is they get orthostatic, then it's going to affect their ambulation, and even worse, it's going to affect their confidence. And they're really not going to be ready to get up again or ready to leave on an early basis. So the normal saline boluses prevent this. Once again, we give 500 bolus upon leaving the PACU, and then another 250 to 500 prior to the first PT session, and then they get another bolus before they get up to go home. Genitourinary system, it's a major concern in middle-aged males with prostate issues. This is our old practice, which we've changed in the past 3 months, was a Foley with the spinal and discontinue the Foley after the spinal wears off. We're not doing Foleys at all anymore. At the end of the case, they're just getting in and out catheterization, and that has worked extremely well. If males have a history of urinary issues, they will get Flomax, but again, there have been some studies now that have not shown that it may not be effective. But we do it anyway because one of the main reasons for a readmission, we haven't had it in our patients, but in other outpatient realms, is coming back for urinary retention. So we have done this already. We've eliminated the Foley. We're using shorter acting spinals. Initially, we used the bupivacaine. Now they're using mepivacaine, which is about a 1.5 to 2 hour duration. So we're able to get the patients up a lot faster, and that has worked extremely well. So physical therapy, they're going to get a session with a licensed physical therapist that comes to meet them either in PACU or in the overnight area. They will get up and ambulate. They'll be taught transfers, get a home exercise sheet, and also do stairs before they go home. Again, they get the bolus prior to getting up with therapy, and after the therapy session, they're up ad lib with nursing. So post-op antibiotics, a lot of people will ask about, well, if they're going home, are they getting post-op antibiotics before they go? So if they stay overnight, they'll get 1 to 2 doses starting 6 hours post-op. If they do go home, they will not get the antibiotic dose. They'll get the 1 dose before they go. Prescriptions, post-op instructions, everything is given to the family prior to discharge that afternoon. A lot of this stuff is given even beforehand, before they go there. Unis from the start have been discharged day of surgery. Totals on our first year, we all came to an agreement that everyone is going to stay 23 hours because we just wanted to have validity to safety of this model. So everyone stayed 23 hours the first year. Now that we're in the second year, I'd say probably 50% or more are going home same day. And a lot of it is, what we spoke about, is community perception. Do they really feel that it's safe to go home same day? And now that patients are seeing their friends and all going home same day, we're getting more and more going home day of. All the DME and post-discharge plans are done prior to surgery. If they stay overnight, they're discharged either by nursing or the surgeon. A lot of times it's hard to get there on time. They have them out by 6:30 in the morning. Conclusion, the key to consistently successful perioperative management is standardization. And the most important variables to control are pain management, fluid management, and technical competency. So we'll get to post-op now.
All right, so I guess I just would kind of follow up. A lot of this stuff for the guys that are here and doing outpatient joints already is fairly routine stuff that we hear in meetings a lot. So this is perhaps more information for folks that are not in the clinical realm, so you recognize what we're doing from the time that we are grateful enough to see a patient and need some help, and that we're able to help them. So we'll talk now about the post-operative course. So once they've gotten through their procedure and their time in the surgical center, what happens next. So we will recommend with anybody that talks to us about this, and if you've gone to meetings, you've heard this, is to develop this confidence with your practice prior to doing this. So as has been stated now a couple times, doing this in the hospital setting, getting comfortable with the verbiage in the office and the perioperative care and management, and also the discussion about getting out earlier. As the length of stays have dropped from 4, 5, 6 days down to 2 days to 1 day, it takes more and more effort from the physician themselves talking to the patients to develop that confidence with their patients. Working with the management programs that we've all been working with, the BPCI programs or CJR, we've learned this. We've learned, again, as was discussed yesterday, where's the waste? Because in the past it was you need your knee or hip replaced, and then we saw you at 2 weeks, 6 weeks, 9 or 12 weeks, and that was it. We didn't really care what was going on afterwards. As long as the patient was happy and progressing, we didn't really know what was going on with the utilization of resources. Obviously, as you're transitioning to an outpatient environment, the idea of going to a nursing facility is non-existent, and we've been trying to work on that anyways in the inpatient realm, minimizing that with preoperative education and support. Working with case management in these processes has helped tremendously. If you pay attention to your case manager and you allow them to do what they're supposed to do. Having a case manager do their work and then not follow their recommendations or discussion with them about how people are going to be cared for, you're essentially going back to the old realm. Protocol development has been discussed. The more that you work on standardizing the variation between the surgeons within one group or the entire group that's working in the surgical center, the easier it is. So there's home health protocols and the outpatient protocols that we've developed or worked on developing together. So from the outside, if you're looking at this, and this was briefly touched upon as well yesterday, is that this is, are these guys just doing something so they're doing less work? But in fact is quite the opposite, and this is the term, the concierge service. I mean, the contacts that the patients have now, I don't know if we've quantified the amount of points of contact that each patient has, but they have to appreciate that. If anybody experienced something 10 years ago and now they experience an outpatient joint procedure, they're contacted multiple times. The conversations and time spent with the physicians or PAs prior to surgery is an extensive change in what they experienced in the past. So we have this increased contact throughout the course, whether or not it's the preoperative education, right when they're discussed, the preoperative history and physical contacts with the case manager, all enhances the patient's experiences and improves their outcomes and satisfactions, as has been noted. So I'm not going to dwell a lot on case management because Jill is going to speak to that, but it is a very important part of this process. And again, as I will, discuss in just the conclusion, you've got to listen to your case manager. Some of just anecdotally from our standpoint, as we work with BPCI, Jill does all the work in our office, and she tries to tell people, number one, notify her about hip fractures, and I'm guilty of that. I try to get gold stars by telling her when I get a hip fracture now. But the quicker she's involved, the more information you can find. She does all her work, and then someone neglects that she's had a discussion with the patient. Okay, you're going to go home and you can do this, and the next thing you know, the doc goes on around and says, okay, you're going to get a sniff in 3 days. It totally blows the plan out of the water. So everything that she's worked to doing changes the care plan. So in the outpatient environment, that has to be followed and managed. And you'll hear from Jill about what she does. But a lot of it is preoperative planning, discussion, arranging through our office that everybody gets their their post-operative medications before they even show up to the facility. We've arranged to have DMEs delivered at the facility, so they're getting an ice machine, they're getting their walker, they're getting what they need prior to if they don't already have that. So again, you hope that there's already a transition in place prior to going to the outpatient environment, so it's not a shock to you or your office or the surgical center. Recognizing what patients actually need versus just the old school way. Again, this is not something new. We've not created this. There are definitely people that are far more advanced in the outpatient environment, and we're learning from them. So we in Greensboro don't pretend to be the tip of a spear, but we definitely are a part of what's continuing to drive this forward. So much again of what we've learned about the post-operative pathways comes from our experience in the quote-unquote waste through BPCI when our experience is there. So we've decreased the length of stay and accelerated the recovery process with less resources, but the still primary focus is on the patient outcomes, and with their outcomes comes their satisfaction. When you're working with various surgeon partners in these situations, you recognize that everybody's practices are not identical, but the standardization that has been alluded to is important to try to narrow that down as much as possible. It makes it easier for everybody around, whether or not it's your case manager in your office or the surgical center. Everybody's point of context is the same, assuring safety and reproducible the results and outcomes. So we do have the post-operative sets, as was that Lucio mentioned in the PACU. We have the 23-hour stay, transitioning to same day PT assessment and treatment and recovery care centers. The beginning of the post-operative care. DME needs are assessed prior to being in the facility, so it's not a guessing game and having to rush to go get a walker the day of discharge. Home health care, a lot of this is evolving. Again, what we've learned from meetings and the confidence that others have gained, but we do not utilize any home health nursing post-discharge with the utilization of fluid management and recommendations and the tranexamic acid. A lot of this issues that we've learned in the hospital setting is not required. Home health physical therapy, again, a little bit of surgeon variability on this. I don't use any home health physical therapy for any knees or hips. Everybody's immediately transitioned to an outpatient environment. Those physical therapy points are set up prior to their surgery date, so they already have that in plan in motion. But we still have an alignment with one of the home health agencies to make that work if folks need that. The utilization of virtual physical therapy with Reflection and Vera, again, gives Jill or the case manager an opportunity. So someone may live in a little bit more remote environment. They're having people come to the house to help them. This is a wonderful opportunity for patients to be at home and have access to someone training. So the touches and contact with their therapist are multiple, maybe more than what we even set up in an outpatient environment. So patients are still getting the therapy and the guidance through a licensed therapist, but are working at home as opposed to having a home health agency come out. Again, it's a more efficient way to get things run. And again, aligning with all the agencies. So all the discussions that were discussed yesterday, we've had these downstream provider discussions ahead of time, setting expectations. So, home health agency, may want you to tip over to that 6th visit, so they then get that extra $1,200 charge. Letting them know what the expectations and what we want to use them for in terms of our patient's success. And then the outpatient physical therapy. So again, downstream discussions, we, through all of our experiences here in Greensboro and then work for Donna, was where does everybody go? Is it in our own office, which is easy? Do they go to another provider in Kernersville or in Asheboro and surrounding areas, or do they go into to Wilmington to do the therapy, or to various places? We need to find out who and where people are going to be going ahead of time. Now, for the most part, now we have arrangements with everybody. And so it's not only the financial adjudication and bills that need to happen through that, but it's also setting up our protocols and what we want. So we have tried to make this outcome-based as opposed to set visits. So we've all, as physicians and clinicians, seen the notes that have come from a physical therapist, like, let's say, 8 weeks into it. And you in the old days, we just signed off on a lot of stuff that came through us. That could have been mortgages and car payments for people, and it could have been more therapy sessions. But you look at them and you clinically look at the patient, they're 0 to 120 degrees, but you look at the PT note and they're like 3 times a week for another 6 weeks. And you're like, no, that's not necessary. So it's more outcome based. So we've tried to set up with our groups, and that we've discussed that we try to get for total knee replacement 16 to 20 visits, again with the outcomes being set forth and the goals that we want prior to them being discharged. 12 visits for partial knee replacements, and limited to no physical therapy for hip replacements. It's still an option for folks to do. I don't do any outpatient physical therapy for hip replacements. And then the VEER concept, as we discussed. So the question then arises, what happens if someone needs more therapy? Well, if you as the clinician determine that they need more therapy, then we've arranged for ours through our overhead and what we have through Delta that we can cover extra therapy sessions. If the patient decides they want to do it on their own, then we say it's not the Delta's responsibility anymore to cover your therapy. If you want to do it, you're going to have to cover the expenses yourself. So as you move into this space, and for anybody that's interested in what we're doing in orthopedics and in joint replacement arena, it's important to do this transition prior to it. Don't just jump right into it. Ease into it a little bit, get educated, have experience in trying to do this on your own. Develop the safe and reproducible protocols, assuring safety, enhancing patient satisfaction, but improving outcomes. And then my conclusion, and you'll hear more from Jill, but work and have this working relationships with the case manager. It's very important to listen to them. It's very counterproductive, and we all are busy, and I'm guilty. I mean, Jill gets upset with me all the time because I won't listen to her about stuff, and it's not because I don't care about what she's doing, but it's just the day in, day out. So it's very easy just to say, whatever you say, Jill, because she's actually having more contact with the patients and what she's finding out in their environments and what they're doing. And as Rowan mentioned, she's going to find things out what didn't come out in your initial evaluations. Like, oh, by the way, I have a Pez dispenser of oxycodone I take. So she's going to find out things you don't do, and then you have to just listen to her and not blow that off, because it's important for the success and the confidence building in the community that this is going to work. And then, as we all have, we've enjoyed the feedback as you compare people's experiences from the hospital to the surgical center. And so as everybody's done this, we've recognized that it's enhanced our satisfaction. It takes a lot more work to do it, a lot more conversations with us in the office, which I think is important to gain the confidence. As for anybody that's not a surgeon in here, that used to keep anterior cruciate ligament patients in the hospital for a day or two. Now that's a routine outpatient environment procedure. And this same kind of idea is thought about and discussed from arthroplasty that once was thought to be this big mystery and this long pathway of pain and suffering. The more we educate folks, the more we're able to improve their overall processes, the easier it is going to be to transition. So in another decade, this will become less and less of an issue. So thank you. Yeah. So I've mentioned Jill's name several times, but just Jill Lauer. Jill's worked with our group. We're Emerge Ortho now, the Triad region. And Jill's worked with us for 4 years. So we hired her when we began the BPCI program 4 years ago. She had case management experience with workers' comp, and then came in and learned the system well, and has been an invaluable resource for us to the success of our programs and patient satisfaction. So she's going to speak on the case management side.
Morning, everybody. Okay, so it's already up. All right, so jumping into the patient risk assessment. So that is the first step. Can y'all hear me back there? Okay. First step into the inclusion into the bundle program. So I do this prior to the patients getting scheduled at all. comprised of a list of questions they get asked. I also do a pretty extensive records review, which is reviewing office records, PCP notes, hospital records, anything I can get my hands on. Patients aren't always honest, and sometimes they forget. I'm guilty of it too. I went to the doctor. You have any health issues? No. Says here you got an inhaler. Oh yeah, I have asthma. So no fault of our own. Perfect example of this, Dr. Olin had a patient a couple years ago, needed a knee replacement. She looked very healthy on paper, had a normal BMI, which is also abnormal. But when I did her hospital records review, she had 3 weeks prior to coming in, had been in inpatient psych for depression and suicidal thoughts. So now Dr. Olin did not try to sneak her through this time. She was not trying to deceive us at all. She really had no idea that that was going to be impactful to her recovery. So because of that, she did not get done at the surgery center or at all. So they're grouped into levels. You know, we have a duty to protect patients and everyone else. So an extensive review is critical. Next piece, plan of care. So that should start at the surgical discussion with the physician. It is finalized with me at the H&P appointment. I see our patients before the PA comes in. We create a care plan. We go over who's your caregiver, what's your home environment look like, do you have stairs, what kind of DME do you need, are you going to do outpatient versus virtual? That comes with a bit of education because virtual is so new for patients. And we use that a whole bunch. Then we talk about education. What can you expect post-op? What's normal swelling, redness? You're going to be constipated. Everybody is. What to do about that? What your dressing looks like? How to properly elevate? Then at the end of that, we do the care plan. I give that to them. I really try to hammer home that I am their contact person at this point. The last thing I want them to do is to call the office, the main office number, put in the leaving a message on the medical concerns line, and then that taking a couple hours to get to me. By the time that happens, they've spiraled and they're panicking, and so I'd say, call me, call me. That leads into concierge level care. So that is the heart of my day-to-day. It is a lot of hand-holding, and not just for the surgeons. Sometimes the patients need it too. So we throw a lot of information at them pre-op. So because of that, they don't really always retain that. They're so focused on that day of surgery and getting through that they don't always listen to the other stuff. We've all heard it, I didn't know. I didn't know it was going to be this terrible. I didn't know it was going to have this much pain. So the bulk of my day is really managing patient and family expectations, dispelling myths, therapy to overcome anxiety because of the pain, education, re-education, giving them a timeline of what to expect today, next week, the week after, all in an effort to get a great outcome and to prevent costly medical expenses by the patient. So again, me being their point of contact, I don't want them to wait hours to get to me. That makes them more likely to go to the ER, to call their PCP, to phone a friend, to do WebMD research. So, yeah. So the quicker they can get to me, the better. So that is also, for the physicians in the room, you constantly saying, call your case manager, call your case manager. That is so important. Then, what's next? Outcomes measurement. So we do Who's and Who's Junior, and thank goodness, because the daddy Who's and Who's is like 40 plus questions. This one is 6, 7, 8 questions. Measures joint pain, physical function. The junior questions are taken directly from the parent questionnaire, so focuses on joint pain, stiffness, function of daily living. The junior allows for faster completion and creates a greater patient engagement. Should take less than 3 minutes to complete. It does if you print it out and give it to the patient. If you do it face-to-face, it is much longer than that. We also do the Promise 10. That assesses general health and function, mental health, social health, pain, fatigue, overall quality of life that they perceive. The challenge with those, it's very easy to get the pre-op one. I do that at the H&P appointment. The 90-day and the year one are a little difficult because people feel better and they're out living their lives and they don't want to do a survey. I don't either. I don't want to buy a car and then do a survey when I'm, happy with it. I'll do a survey if I'm not happy, but not if I'm happy. So that's where the physicians come in. Again, your patients will do whatever you ask them to, quite honestly. Dr. Alucio had a patient a few years ago, cranky lady, never got warm, fuzzy feelings from her. And I saw her in PT about 4 weeks after her surgery. She said, "Don't you just love Dr. Alucio?" I'm like, "Yes." And she said, I kid you not, hearing from Dr. Alucio is like hearing the voice of God. Horrible. And my point in that is she would have done anything, survey, whatever. So that would be very helpful going forward. It is such a simple little thing, that survey, but it is a bear for your case manager. So ask for help with that. My experience, so I have done case management a lot of places. Started in insurance, United Healthcare, transitioned to hospital case management, SNF, work comp prior to this. Case management focus has always been about high quality care, low cost. But this has changed the way that healthcare is delivered. And that is so exciting. We get to challenge the old way of doing things. We are empowered. Out of the box thinking is encouraged. So it's been awesome. We all, as case managers, have felt like, well, I'll just go in, I punch in, I do my work, I punch out, I go home. This is worthwhile and valuable. And any of your case managers, I'm 100% sure would agree with that. So it's nice to be part of something that is affecting the bigger picture. That's it. Thank you.
Thank you, Jill. If this is the voice of God, we're in a lot of trouble. So I'm going to talk about our first 350 bundles. Let's talk about clinical data first. So this is our breakdown of unis versus total knees, total hips, total shoulders to add up to the 359. As we stated before, as Steve stated yesterday, the first 6 months of the program at the old center, we did nothing but uni-compartmental replacements. And when the new center opened in August of 17, that's when we started doing our totals. And the numbers have really grown dramatically since we got this started. I guess we're 19 months now. So let's look at our clinical data. Our infection rate, 1 infection out of 359 cases, 0.3%. This is as good or better as any inpatient facility. One of the things we're operating on the younger patients, the total knees on the younger patients, these people are going to have a higher rate of stiffness and higher necessity for manipulation, but our manipulation rate is only 2.5%, so only 6 patients out of the 150 or so total knees. This is in line or as good or better than what we're seeing in the inpatient setting. Reoperation rate, there were 4 reoperations, 2 closed reductions from hip dislocations. One went total knee, had to go back for hematoma washout, and then the 1 infection. So only 4 cases, 1.2% reoperation rate. ER hospital admissions, so readmission, 0.3%, and that was the infection. If you look at the inpatient setting, you're looking at 3 to 6% readmission rate. This is extraordinarily low, and it just goes to show the safety of the program, the safety of doing this in an outpatient setting. DVT rate, 0. So let's look at our outcomes data. So the Coos score, the Coos Junior, looking at the knee scores, preoperatively starting at 47, and at our 90-day went up to 72, very nice jump. And for the patients that did the one-year surveys, the improvement was maintained or got even better at 1 year. Looking at the hips, pre-op to post-op at 90 days, very large jump, even better at 1 year post-op. So these are very satisfied patients functionally, and then they ask about, are they satisfied with doing it in this setting? Through the roof patient satisfaction. For every single one of us, we've all discussed this, all of our patients that had a hip or knee done on an inpatient basis and then did this for their other side, they were all like, why did you put me through that the first time? They were all extremely satisfied with doing it in this setting. And if they had a choice to do it again, they would do it in this setting, and they will tell all their friends and neighbors to do it this way if they're eligible. Financial outcomes. So for the surgical center, this was a completely new business and revenue stream. This is a high facility fee for highly predictable cases. When we went in to discuss a facility fee, we said we will keep it at the same level or a little higher than your highest facility fee now. And it's been a very good source of revenue for them. It's 350 cases so far, or 360. For Delta, for our group, we get to control costs. So in the value curve, quality divided by cost, we can control all the costs, so our value is going up. Not only that, we've maintained or improved the quality of care by doing this. So like Steve said yesterday, it's a double bonus of value. We've improved or maintained quality while decreasing cost. And for the surgeon, there's a lot of extra work in doing this. And we have a metric-based incentive program, so at the end of the 90 days, if you meet all the metrics, there is a increased reward for the surgeon at the end of 90 days. For the payer, well, it's been a huge win for the insurer. They've collectively saved over $4.3 million in transitioning from transitioning from inpatient to this setting. So it's been a huge win for them also. So Sean, you got your 30%. 10% next time. So that's our first year and a half, 360 bundles, and we're all going to come up. Let's get everybody up here if there are any questions.
So Jill, come on up. And Donna, if I can give this to you. Excuse me, Jill. Jill, check how we... Oh, we only got one. We'll figure it out. We had some feedback yesterday. Some of the questions weren't heard, so Donna will be our Vanna White for the morning and pass the mic around. So questions from the audience first. I have some questions I've written down, but Sean, go ahead.
A few questions. Thank you. First of all, to Jill, I love that idea of screening patients based on hospital records, but if you're taking them to a facility and you're screening a different facility records, how is that HIPAA compliant? Do you specifically ask if you can review their medical records in preparation for their surgery?
There are patients, oh gosh, sorry. There are patients, so I don't know, is that not HIPAA?
You can speak.
Yeah.
Your license are in, you're looking at their medical
Yeah.
record.
They signed those HIPAA forms when they came to see you, and so the people that work for you fall under the HIPAA form that's in your medical record, in your electronic medical record.
It's been a little bit of a hassle getting the inpatient hospital system to allow them access to data. They finally fixed that, what, about a month ago? You got access.
Well, I mean, I had that barrier. If I'm trying to find outside records and stuff like that, I have to get a medical release form separate than me just surfing on my own that gives me that. So I know that you're looking specifically for your facility is that another layer that the case manager needs to make sure that they have vetted before they start screening these patients?
Well, I think so, because if we don't do it at the surgery center, there's potential to do it at the hospital, so those records are going to be relevant.
So had they been identified that they're already going to the ASC, or this is the process
is-
to determine?
Right.
Okay. The other thing is that, why don't you guys, I mean, the literature showing that IV and oral Keflex versus Ancef have identical tissue penetrance. Why don't you just put everybody on oral so you don't have to delineate one gets a couple more doses because they're 23 hours, the other's not?
I think the other thing, whoa.
That was the voice of God there. He's not going to live that one down. It's going to keep coming back.
Thanks. No, I guess right now we're actually studying whether any postoperative antibiotic is necessary after a total joint. But you're right. I mean, we easily could give them 2 doses of Keflex if we wanted, but we're just determining whether it's even necessary to do any.
For primary total joints, I've used post-op antibiotics since I was a fellow in Atlanta. And there was a good study that came out, I think it was JBJS, where they looked at a very large cohort, like it was 20,000 patients. There's no difference between for primary total joints, and they didn't even stratify if they had, like autoimmune problems, but there was no difference in the infection rate for post-operative antibiotics. So the real question is, should we be giving them at all for primary total joint?
Well, the only thing, last month in August, they showed decreased complication rate in high-risk patients with extended prophylactic antibiotics for 10 to 14 days compared to the routine 3 afterwards. So it's kind of it's still unknown box, and I think it's going to be hard because we do such a good job. The numbers that you really have to look at.
Huge numbers to show a difference, I agree with that.
Yeah, because high-risk patients are going to be
Agree, I'm just trying to extrapolate.
Oh, yeah.
Yeah, so one of the things, kind of dialing it back to the standardization, is a great question. We grapple with the same thing, whatever. But the nice thing is that we have that discussion. We look at the journal articles, and then we make a decision as what our standardized order set's going to say, and then everybody does the same thing. So you can't give Keflex, and I give 3 doses of Ancef, and Frank does 2. We make a decision, and we stick by one decision. We may change it 6 months later to a different decision, but at least it's one thing for them to worry about over at the surgical center. Other questions? Dr. King.
Yeah, 2 questions. Could you clarify your policy with Foley catheters again? It sounds like you're just doing a straight cath. And the other thing is, how do we clone Jill, who's willing to take calls 24/7?
Well, let's talk about
What
the
happens
catheters
if-
first.
What happens if you're on vacation?
I'll talk about the Foleys. That when we initially started out, they were getting bupivacaine spinals with variable amount of time lasting post-op. So it was anywhere from 3 hours to 6 hours. So they had, at that point, they were getting Foleys. And when we switched to the metpivacaine spinal, which lasted an hour and a half to 2 hours, we stopped doing Foleys. But the problem was, in the PACU, the nurses were saying these patients have full bladders and they're leaking. And it was embarrassing for the patient. It was more work for PACU. So we started doing straight caths at the end of the case, and that eliminated the issue with urinary leakage.
And I think, at meetings, this is a topic that comes up. Guys stand on the podium and say, we don't use Foleys at all. Well, you've tried that. There is the PACU. There's the nurse issue in the PACU, and they were very disgruntled, and it's a problem. And so I've continued to ask folks, and straight catheters are a solution to that. Some people said, yes, I see the same kind of feedback from the nurses. It's horrible, so they've gone back to catheters. Other guys just say, I don't care what the nurses say, I'm just going to let them with. But after they've changed the bedding and their gown 3 times, I mean, it gets pretty frustrating for them. So whatever works in your PACU is what you should go with.
We've got the same issue. Do you do it in the OR or do you do it in the PACU? Because it's nice to save the OR time, not having.
They're doing the
OR.
Or
Yeah.
they're pretty quick though. If they know they're doing it, they got the kit there, they go. It's a couple minutes.
And getting back to the bupivacaine spinal, even that, there's variation. Apparently, if you change by 5 milligrams, maybe a 2.5 hour spinal, a 2 hour spinal, an hour and a half. And I've actually got to the point now where I know what one guy gives for an hour and a half spinal. And I've asked the other anesthesiologists please use that dose. Because some of them will give a higher dose of bupivacaine, and you don't need 2.5 hours, and that's a longer time where they can't.
Good question. The Jill question. Jill, do you want to answer the question about cloning yourself or giving yourself?
She does not get any vacation. And she works all the time. She's trying to get some help, and we're still not letting her get any help.
So, Jill, I think a fair question would be, do you actually give them your cell number?
No. I
Okay,
don't.
thank you. That's a good
No,
answer.
and
So what do you do? How do you accomplish the not dialing the main number, and how does that work?
Well, I tell them I'm there Monday through Friday all day long. So, and I try to call them as much on the front end as I can. So, you know, the discharge calls obviously get a lot more attention. The 1 week calls, as they go on, they shouldn't have that many needs. But you know, we have on-call physicians after hours, so that's on my voicemail if they call in, you know, on the weekends or at night. But just up front, I try to, and you know the ones that are going to be a little extra needy, so you call them a little bit more.
We have discussed having maybe a PA, paying a PA, a joint PA, total joint PA, to be an after-hours phone number for the whole group, for the whole Delta system. Because what you don't want is them calling the foot guy or the spine guy who then just says, I just go to the ER, and then you got that leakage. So we have talked about that, and I think we'll probably get there with volume. So, other questions? Yes, sir. She's for one practice. We have one for each practice. Each practice has their own case manager. And our volume is probably getting to a point, I think the number's around 150 patients to 200 patients a year, is that right? That a case manager can manage, and then something like that?
They're also taking care of DPCI, and we have a bundle starting with our ACL now as well. So there's volume.
Yeah.
There's 3 case managers in the city.
So, but the ratio is what, 100, you say 150 cases per case manager?
I don't think we've hit it yet. You were going to say something. I think that's what we heard.
Yeah,
Just like we heard you don't
combined,
need Foley's, though.
You don't EPCI, just that you're going to do bundles for commercials.
What would you say, Jill? What would be your answer?
How many have we done?
No, how many do you think you could handle by yourself before we...
Commercial.
Commercial, probably 300, 350.
Okay.
If that's all you're doing.
Commercial ones are easier.
Yeah, so
They're helping.
no other case manager, you start fresh, you're just doing commercial bundles, 300 cases a year per case manager.
Right.
So one of the things you'll see in the tool that we've built, the software tool we've built, is to try to expand their margin so they can care for more patients because it's systematized, from a software standpoint. She knows what calls to make, she knows who to call, push the button, that kind of thing. Other questions?
One last one.
Sure.
The after-hours calls, you have to train the whole practice to how to handle routine kind of calls about this and that, or do they have they call the PA, takes the call, and then do they have the ability to call you if it truly does need case management?
We don't routinely give the patients our direct cell numbers, no, but
Routinely, never.
part of we're going to talk about risk management. Part of the risk management is educating your partners also, your non-arthroplasty partners. And you got to tell them, you can't press the easy button. If someone calls with a problem, you do not send them directly to the ER. I mean, if you think it's a substantial problem, call one of us and let us know, and we'll deal with it. But don't send them to the ER.
You set up a program of improvement multiple hand surgeons fund. That's exactly what I tell my partners. Look, if you really think it's something, call me, call my PA.
Yeah. So we're still working out. We're still learning. I think we will hit a point where we have to have a call situation to receive calls for our outpatient bundles to control their, answer the questions, keep them out of the urgent cares and the ERs. Question for Olin. Share with the group what we did. We were a little concerned because we were bringing this total joint service line to an ASC. They've never mixed cement. They've never put in an implant bigger than a rotator cuff anchor, and there's a little bit of angst there. So tell them what we did to kind of strategize and get them ready.
Well, as we were first making the transition, obviously we started doing partial knees, but as we developed a new center, we did do a little bit of a team boosting event at one of the local bars and breweries, and rented out the top floor and had all the vendors bring in all their equipment so they could all get a chance to hold and see and smell and do everything that needed to be done about that. And they appreciated that a lot. It gave them a good boost of confidence as they led into the experience. And plus, we've had some folks that have worked at the hospital and have transitioned and work now over at the surgical center, and said they've been invaluable in terms of educating and needs and how workflows go.
Yeah, we need to get, we took pictures that night. We did the power tools before the drinks at the pub. That was very important because the nurses did the knees and the hips and we assisted them. And it was really fun. It was really crazy. And very glad we did the alcohol after the power tools. I have a great picture of this nurse with this hip reamer, and she's just loaded up with that. Chips are flying. It's hilarious. They appreciate that, and really just that it showed, I think, a recognition that we cared about them and that we wanted to train them and wanted to embrace them. They're part of the team, you know, that kind of thing. I wanted to ask Eluzio about the same day to the overnight to the same day transition. I know all of us have gone around on afternoon rounds, especially in the early months of the program. What was your experience when you went in the afternoon after doing a total hip or a total knee over at the surgical center?
The patients physically are ready to go. They've done their physical therapy, they're ready to go. It's just a matter of, psychologically, are you going to go or are you going to stay? And it's just a matter of coaching them and saying, all right, you can stay here, we have it arranged for you, but you've already met your criteria. If you want to go home and sleep in your own bed and get your medications when you want, you can go home. So, now that we've started, our first year, we said we're keeping everybody. Now that we started doing this, I would say, 50% or more, maybe even more than that, are going home now, day of.
I'm sending all of mine unless the case manager says otherwise.
Yeah, I like to see them before they go, and my issue is I do clinic in the afternoon and generally don't get there till 7 p.m. So at that point, a lot of them are like, I'm just going to stay.
Well, that's one thing. It's a 23-hour observation, so they leave at generally like 7 a.m. or 6:45 or something. They're out the door. So if you go around on rounds at 7:30, you've missed it.
And so, we're one of our charges, or at least one of my charges this coming year, is to work on the flow of our surgical centers. So, again, this is not new, and it's been done across the country. So you go to meetings, and the length of stay in a surgical center is 7 hours. And so, we now want to make that happen. Again, keeping that probably within the 4 of us initially, and then kind of expanding as the protocols become a little bit more secure. But what FTEs do we need at the surgical center to get them an hour and a half in pre-op, an hour and a half in the OR, and an hour and a half in recovery room and out the door? What do we need as a system to make that happen? So we've kind of gone through an ease-in process of a year and a half to get everybody used to this, and now we're going to push the accelerator a little bit and make things a little bit easier. But it is nice to have this person needs to stay a little bit longer and have the access to that. But that's our next year or so project.
I found that they were in no pain. The spinal and the adductor canal block and the expro and all that. I'd go around at 5 o'clock that afternoon, and they're in no pain. They're wearing street clothes. They're watching Netflix, and they're eating honey baked ham that they ordered, that the surgical center ordered for them. And it was a total social visit. And so really, the one night stay is really more of a case management issue for me than anything else. It's really Wednesday. I do them on Monday. So between the spinal, the adductor canal, the exparel, everything's gone on Wednesday. So maybe you do your surgery and you bring them back 2 days later, but keeping them overnight is making less and less sense from a pain standpoint. So, Jill, just the sniff test. So you got your questions. We have these nice risk assessment questions that Dr. Rowan has given you and the other case managers as who's appropriate and the type of patient. But you mentioned it, there is a sniff test where it doesn't matter what the question, how they answer the questions, you kind of know who's a good candidate, who's not a good candidate. You've seen that.
Oh, for sure. Yeah. And sometimes it's not even, there's nothing on paper that, it's just a feeling. And you go back and you say, this lady's going to do terrible. I know it. And they don't care. They're like, did she pass the test?
So,
But, and sometimes I'm wrong. I'm wrong, but Sometimes, yeah, it's just.
most of the time you're right.
Well, they just tend to be they need a little more hand-holding. And sometimes you call patients and it's time for them to make coffee and sit down and talk to you all day, and that's just good customer service. But yeah, those are the patients, the upfront where there's something about them that you just know it's going to be a little painful.
Yeah, so I think there's a good learning point for the doctors as physician leaders who are here. Number one, listen to your case managers, and if they say, I don't think it's a good idea. And then if you're the physician champion and they call you because you're the one running the program and you have a partner that's trying to sneak one in or something, and Jill has an issue with that, Jill's emailed me a couple times, and I've had to say, okay, and every time, 100%, I'm backing Jill or Lisa or Renee. So physician champions, whoever's the leader of the program or the group that's leading the program, you could override a score and say, okay, we'll do that one. But you need to back up your case manager if they say, Dr. So-and-so is trying to do this one. I don't have a good feeling about it. You just got to call Dr. So-and-so and say, we're not doing it, and just take the heat if you have to. We haven't had much of that, but we've dealt a pretty clear message to our partners doing these over at the surgical center, and we definitely listen to our case managers. Any other questions? I have one more. Any other questions that you have? All right, that's good. I wanted to ask Frank Alucio about, he has the most experience with virtual PT and the Reflection Health product with Vera. So just give us a word on how that's going, how that's gone, and kind of what you hear from your patients.
I think that virtual PT is the perfect marriage with a bundle. We were involved in initial clinical studies looking at virtual versus standard PT in total knee patients. It was a multi-center study coming out of Duke, and the clinical results were virtually equal between the two. But from a bundle standpoint, the financial savings was enormous, and the patient satisfaction was tremendous also. So if I had my withers about it, I would have every one of my patients do virtual PT, but some of them still don't want the concept of not having hands-on. So it works. It works extremely well, and it's extremely valuable in a bundled situation.
And they're here if you want to get a little demo of how that works. Pretty impressive technology. I want to ask Donna. Oh, go ahead, Matt. Yeah.
I was just going to, just from an educational standpoint and from an upfront standpoint, I'm the guy that had the infection. And as we kind of look back at processes at the surgical center and then through reviewing with Jill, the guy that had the infection, he was a diabetic, but his A1C level was 7. So I did not skirt him by with 7.5 or 7.6. He was at 7, so we felt that was okay. He had a prior surgery in his inguinal crease area, and I believe it was like 20 years prior. But there was no problems on exam prior to surgery, nothing. And so, and at the time of the procedure, there was nothing obvious. I didn't go through a pus pocket getting down to his hip joint, so it wasn't like some remote abscess that had just been sitting there. And so from a process standpoint, I think that we had done all the right things. I don't know if it could have been prevented. I don't think it would have been any different if he was done at the hospital versus the surgical center. I did have to take him back and did a headliner exchange on Indeed, and it treated his infection without having to do anything further. We took that back and learned both from the surgical center, did we do everything right? Is this a pattern, or did something happen? And also from our process in the office, did I twist Jill's arm too much and she let it happen? But it didn't seem to be. Process-wise, it was done right.
Good. So Don, I have a question for you because it was brought up about the downstream providers and the tight post-operative pathways and protocols that we have. 16 to 20 visits for a total knee, twice a week for 6 weeks for a partial, et cetera. What's been your feedback from the downstream providers? We have like 18 different outpatient PTs that have signed contracts. Do they like the program? Did they not like the program? What's been your feedback as an administrator?
Well, I can tell you from the initial phase of it, one of the things that I will always harp on is the fact that physician leadership is key in this whole program. And what they decided to do is to engage these folks in trying to help them determine what the right thing was for the patient. So they didn't simply make the decisions on their own. We brought in a group of PTs, and we talked to them about that. What do they think is not only the right amount of visits, but also a fair rate for these visits, and that's how this was determined. Not only were they excited to be engaged in this decision, they were totally supportive of this idea, and we have phenomenal feedback from them as far as participating in the program. The only challenge that we've had from that aspect is there are some concerns of using your own PT shop in-house. They were certainly included in this decision, but we also engaged some of the outside PT facilities just because we needed them to be involved as well. What we've since learned is that having them involved and engaged, I spend a lot of time communicating with them too, because they'll have a certain situation with a patient as far as someone who has achieved their goals but still wants to keep coming for PT, and can they do that? And the answer is really no. If they've achieved their goals, no. But in the arrangement that we made with them, we're going to pay them one flat rate for 18 visits for a need, and during that time, what is able to happen is if they get the patient to achieve that in 12 visits, they still get the same amount. But we also ask that if it takes them a little bit more on another patient, to please continue to care for the patient until they reach their goals. But they love the program. And as soon as word was getting out that we were trying to do something like this, I found myself receiving phone calls from outpatient PT folks saying, can we be part of the program? We think it's a great idea and we want to be involved. The other thing that I do with our patients that live out of town, we needed an option for patients that either don't have PT facilities nearby or transportation issues, and that's where Reflection has been wonderful. This is what they can do in their home. That was another great alternative for our patients, but we've had such great patient satisfaction from that tool and the study that Dr. Aluzio was involved in with Duke, that it's a great option for patients also and more affordable for us. So we have looked at it, we're molding into all kinds of different things. I do have certain situations where it may be the patient is traveling here from the mountains and they want to go back there and they want to have PT with their PT folks that they've had used before, but it's not enough to do a whole contract with them because we're not going to have many patients. So I will place a phone call and I will ask them if they will agree to do it for this particular patient. I have never had anybody say no. They all think it's a great idea.
That's good, thank you. So yes, Stefan?
Question, what percentage of your commercial full knee patients can you do in an outpatient setting, or are you doing it in an outpatient setting?
So the question is, how many of our commercially insured patients, total knees, are we doing in the outpatient setting? So we made a decision to only do them under bundles. So it's a little bit of a different question, because if we had a bundle with United Healthcare, which we don't, then if we had 100 patients who were commercially insured by United Healthcare who went through the risk stratification and qualified, we do 100% of those. So for Blue Cross Blue Shield, all type 1 and 2 patients who are commercially insured are done at the surgical center, 100%. Aetna, 100%. Cigna, 100%. So as we get a bundle, we don't do it without a bundle because as we're talking about, this is an incredible amount of work. We keep saying that. Well, it's the side of service shift and the amount of money in the system that we're using to invest in the program. So if we don't have enough money to invest in the program, we can't give Sean the 30%. It can't happen. So it can only be done in a bundle payment program. That's just here in Greensboro.
So for number-wise, 550, 600 joints a year, I did about 50 last year, 50 or 60 last year. So 15, 20% right now, but it is dependent on insurance.
So let me make sure I understand. So every Aetna patient is done in an outpatient setting, or how many does Jill say, yes, this is a bundle patient, but we're going to do it in the hospital? That's the question.
So our risk stratification tool types them as 1, 2, or 3. The 3s are not done in the outpatient surgical center. Well, literature-wise, it's about 20%. So in the literature, 72% are ASA 2/3, and that's the most common total joint patient. So we're trying to capture that entire market going to the surgical center, to outpatient. So it's just the type 3 patient. As I predicted yesterday, I think we're going to be doing 95% of everybody because it's still a cheaper place to do the index procedure. But currently, type 1s, type 2s, our estimate is around 75–80%. And so our goal is to get everyone under contract, and then 75–80% of the commercially insured will be outpatient.
And the second question, what percentage of your patients get this technology and what percentage get PT? What's the mix there?
Jill, and then from our office. And it's just the Delta group.
I would say half.
Half,
From our group, from our office.
yeah.
Yeah, the different groups, there are some that are not using that as much. They're using it more for just remote because they have PT in-house, and they're just kind of getting started with it. But they've been involved with it for a lot longer, and so they're using it a lot more frequently.
Yeah, and Steph, in my practice, I'm in a different practice, and so I haven't used it yet on a patient, and I want to. And so I told my case manager, let's find the patient, let's find the patient. I have a little younger subset because I do knees, so I have a sports side and a joint side to my practice. And a lot of those folks have had their ACL rehab 4 years ago or their knee scope rehab, and they want to go back to their therapist. But I'm definitely excited about the technology. And I think in the BPCI or the Medicare bundle, the Medicare Advantage bundle, I think it could be a home run. Control the cost there. Edward?
Can you all address how you deal with implants and implant provider negotiations, and if any of that is standardized or anybody uses whatever they want, and those issues? Or maybe that's going to be covered later.
No, I'll take that one because it was the shortest negotiation ever. They're here in the back. They don't mind me talking about it. Here's the price. It's an all play. End of discussion.
So you have to take a price, and if anybody wants to.
Here's the price. It's an all play.
We've not introduced robots. Capital costs, the surgical center, we did have to buy a Honda table. We're going to have some food drives for another Honda table. We have not introduced that into the outpatient environment, nor have we had computer assisted needs. So that's
Yeah, they're a partner in this too. They're an industry partner in this too. So our MO with the company, with the effort, is anybody that's going to touch the patient or something that's going to go into the patient, we want to pay them at or above the rate they used to get paid to keep them motivated and interested in what we're doing. We want them to take excellent care of the patient. So the surgeon, the anesthesiologist, the implant, everything's paid well. And so we're not trying to make a buck on, decreasing this cost or that cost or whatever. I mean, I'm sure the day will probably come where we have to entertain some of that, but the shift of service, there's enough money there that, especially the people that are caring for the patient, need to be paid well. And they're so happy. Our anesthesiologist, everyone's happy. So there was another question over here. Yes, Dr. King.
Yeah, clearly this is a very disruptive process. And the people you're disrupting are the hospital systems. There's already a lot of pushback on this. We've seen this for 60 Minutes. And one of the areas that they're talking about is, well, you're going to have a higher infection rate. Your infection rate is clearly very low. I'm wondering if you use Erocept, which is dilute chlorhexidine gluconate. I can't prove that it works any better. My infection rate, been doing outpatient for the joint swell. My infection rate is 1 in 1,300. I can't prove that that's related to that, but it's very cheap insurance and makes me feel better. I'm wondering if you use anything like that, or maybe dilute betadine or something like that.
Frank?
We do not have that in our protocols. The betadine issues come up a lot with the sterility of the betadine, and I guess there's a couple companies out now that produce the sterile betadines that may come out. But we learn when we go to meetings and hear from folks, and so it'll be something we'll consider as a possibility. Because of course, the safety is paramount for the success of it.
It's a good question.
The Erocept gets around that with the betadine, and it actually works better, and it's not toxic to the tissues.
Yeah.
You doing that as an irrigant?
It's an irrigant.
It's an irrigant,
And
okay.
we use it very liberally throughout all cases. And when you make a skin incision, you're dragging in about 1 billion bacteria. And so we use it right after we make the skin incision, we douse the wound, and then we'll use it throughout the case, considering that you're always getting contamination in the case.
That's interesting.
You can use it with anything.
That's good.
So,
Stephen?
I think this begs the question that maybe next year we could have a little group discussion what we all do that might change pathways. So consistency shouldn't just be with you four,
Yeah.
but with all of us. Because I use Aricept as well, and I like it. And
That's a great point.
I use silver pegnated dressing, which I think is all the things in sliced bread. So there's a lot of, you may have like a work group. Or
Yeah, maybe we do a breakout sessions and send the case managers one way, we go another way, and we do kind of a roundtable discussion of, best practice, if you will, but, best practice put through the lens of literature and then also practicality of what can be done in an outpatient surgical center. It's a really good point. We'll do that. Any other questions before we break? Sean?
So, you guys obviously put a lot of work and resources in this. Do you have concerns as providers who try to do this without having the proper protocols and case management and all that in place? And should there be an accreditation, process? Should the payer have a role in being convinced that, they have the right structure in place?
It's a really good question. Is there a concern that do we have a concern that providers will do it without all the work and the systems in place? Well, it's already being done. So yeah, we have a concern, and then there's articles that are written that say that outpatient joints aren't safe or whatever. Interestingly, most of those articles are published by big, large inpatient hospital systems. So the truth will come out. But I mean, of course. Yeah, of course. I mean, there's a relationship. It's a good question from a payer, Sean, because one of the reasons we're doing this is so you and your counterparts in the payer world can tell, we're interested in patient care, we're passionate about patient care, but it costs a lot of money. And so to ask for not to keep beating you up about 30%, but asking for the 30%, it's like, what are you getting for 30%? A bunch of money. What are we getting for our part? A lot of work. So we need money too. So we can't discount but so much, or we have an overhead problem, and then we got to go to our implant guys and say, I can't pay you, and the anesthesiologist will squeeze them a little bit. Right now, the side of service shift gives enough money to pay everybody really, really well and set up a program that takes really, really good care of patients. So yeah, so we're just passionate about trying to share that because we want people to do the right thing, not just because you can do it in an outpatient surgical center, but because the patients do really well.
Let me expand on it a little bit more also. I think if, in a fee-for-service setting, you're not going to be able to control who does an outpatient joint. In a bundled setting, there's going to be a lot of control, because there's a lot of extra work, and you're not going to get a lot of surgeons that want to do all this extra work to do it unless they're dedicated to creating their own program. I think that's going to be a very big aspect of it. And B, you're going to be able to choose who you want to have a relationship with in a bundled situation.
True.
The other comment that I'd say is that for the most part, I would tell you that arthroplasty surgeons, guys that attend ACUS, the guys that attend these meetings, any meeting, are going to be very responsible how they do it because they're aware of the concerns of the care for their patient. It's the guys, the sports guys that are thinking, well, I'm going to just throw a total knee in here. I can do it, I've done ACLs. That's where you may run into some of the problems that may not have the protocol set up. So, hopefully our objective with Valere is to get this message out as well as the other guys that are doing it to set this up. But if you go to meetings, and that's why I wanted all the members of Delta to be ACUS members because it means you have to go to a meeting every 3 years in order to be an ACUS member. But we just set a number of joints, and so we're policing it ourselves as our kind of board.
And I believe there's a certification program going on now where you have to meet criteria. You have to submit to AJRR to be considered a Center of Excellence by CMS as an ASC.
Yeah, blue distinctions.
The industry is moving that way.
Yeah.
Yeah, so that was, my question is, obviously we don't have any contracts for bundles with payers, but if we were to go to them and say, we have this, what is the magic word that should give them comfort that we are capable of doing it?
I mean, it's a clinical system to care for the patient. I mean, one of the things that I see, won't name companies, but a company will go and sell a robot to a surgical center for $1.4 million, or two of them, and they promote that and they market that in the community that the surgeons are, we have this new fancy robot, and it drives a lot of volume. And the guys doing the surgery with the robot are typically what I call sports arthroplasty surgeons. There's guys who, live in a surgical center. They want to grow their business. The company comes in beside them, gives them a discount on the robot. They put the robot in the ASC, and it's a marketing play because the robot is not shown to be clinically superior. So there's a lot of that type of stuff, Sean, that goes on for marketing and for volume, and we're not about that at all. I mean, it's not, our marketing is our results. So, any last questions before we take a break? Okay, so believe it or not, we are like way on time. You would think we were like, when was the last time we started a 7:30 case at 7:30? It's amazing. So we'll take a break and we'll be back in about 15 minutes. I think there's some food, coffee, whatever, and then we'll jump into business pillars. Okay, we're going to get rolling with the business pillars to put this outpatient thing together. And, the clinical piece is very, very interesting. Hopefully the industry partners and the payer partners found that interesting. I think there's some value in hearing your doctors talking about things like transdynamic acid and Foley catheters, and then it's, we're taking care of patients. But if we've learned anything, it's been in the business, on the business side. So, I'm encouraging now the physicians to pay attention specifically, because you're going to hear some things and learn some things. And just by virtue of you being here, you've kind of self-selected as the physician champion for your group. So, that's excellent that you've given your time. So we're going to go down a list basically of, you remember our triangle of alignment. So we're going to have our ASC CEO speak. We're going to have Keith Miller from Blue Cross Blue Shield of North Carolina. And we're going to keep going down and talking about the various business pillars. We mentioned these in the talk yesterday. So each person will come up. I'm actually going to pitch it for the attorney. Just one slide since he couldn't make it. But first would be Jenny. And Jenny, as she's coming up, Jenny is an RN, used to work with her over in the inpatient environment years and years ago. She took over at the surgical center, totally turned it around. At the same time we launched this outpatient joint program, she opened the surgical center day one. How many cases on day one? 88 cases the first day the center was open. Seamless. Her leadership is impeccable. So we're incredibly grateful and just fortunate to have not only a great facility, a great hotel across the street, but a great leader in Jenny that partners with us just exceptionally well. So.
Thank you, Dr. Lucy. Could you spread that to my kids? So obviously we mentioned the word alignment a lot, and we've always taken that word so seriously at our center. And that alignment comes from our focus, which is the clinical quality for patients. And our commitment to clinical quality aligns us with our patients, aligns us with our payer, and aligns us with our surgeon. So that we always keep that first and foremost. Secondary is cost containment and our alignment in that. And again, aligns us with our patients, aligns us with our payers, and aligns us with our physicians as well. So we take those very seriously. As far as the total joint program, it was such an exciting opportunity for us to delve even deeper in our alignment with our physicians and with our payers, knowing the benefit was going to come out from that patient side. And for my team, such thrill just to be able to start this new service line. And again, I think Dr. Lucio talked on it briefly of, we had started at the old facility with unis and kind of dipped our toe in it, if you will, and then just head down once we made the move of going into a full total joint program. New revenue source for us, obviously, which is fantastic. Some of the challenges, we have had to work on our block time and outlay of capital equipment, the training of the staff, again, the alignment with our surgeons, alignment with our reps, and the training that it took to get the team up and running, and everyone was on the same page to make that happen for the benefit of the patient. I know it's market specific. Obviously, we are the only freestanding, non-affiliated facility in our market, and so it's probably not looked at well from the hospital side because those patients are coming from hospital to us. So I think it definitely depends on your market and how you make that move. Your ownership too within the facility, the joint venture that needs to happen as well. What we have learned is aligning ourselves with our physicians who have great business plan, business model. Keep the patient focused, number one. That is absolute key, and you do need the physicians to champion that. They are the ones that are the interface with that patient. They are the ones that are making the key medical decisions for that patient. And we've trusted our board-certified total joint surgeons to lead that program for us, and we needed that. We needed the standardization that they brought. We needed all the tools that they brought, and it's just been a great partnership and a great opportunity for our facility. So, thank you.
This is Keith Miller with One Con Blue Cross. Jake was here last night, and Keith's here, and those were the two that we worked with. I've just seen them for quite a while.
Yeah, good morning, everybody. Again, thank you for letting me be here. I am, Jake had some previous commitments for the day, so I'm here in his place. So I appreciate you letting me kind of duck in for this. Let me go ahead and advance it out. So figured I'd just kind of talk about kind of the experience we had with the contracting process, and then really kind of get into the challenges that you guys might face when you're dealing with a payer based off of the experiences that we had in the perspective from Blue Cross of North Carolina. So this first bullet, I always laugh at it. It took 8 meetings, and I guess you could, depending on your perspective, is that a lot? Is that not enough? You know, but it felt a heck of a lot more than 8 meetings, that's for sure. But at the end of the day, we did get it done, but it was a lot of work, a lot of coming together to make sure that we understood each other's common goals there. So what are our biggest challenges? From a payer perspective, there's 3 main things that I'll tell you that you'll probably run across. And again, I'm speaking specifically from a Blue standpoint. There might be other national payers that have a little bit more infrastructure built in, but the 3 are data, resources, and our system limitations. Those are probably the 3 biggest things that we had to kind of work through from a data standpoint in our experience here. And the Delta contract was our second. We had our first primary partner back in 2013. Great relationship with them. It worked well, but it definitely was our pilot, not scaled, obviously statewide, and a little bit homegrown as far as our data goes. But when we came in for the expansion, really, we started looking at budgets. It was truly taking claims data, putting it in Excel spreadsheets, pivot tables, whatever creative way we could come up with estimating a 90-day spend for a bundle. That was a really hard way to come to the table and get to a common ground on what that 90-day spend actually looked like. So that was number 1. Resources. So for a lot of payers, it's still exploratory, obviously, for bundles. Blue Cross of North Carolina, we've still got a long way to go, but we've been out there since 2013, and now we're full-fledged, ready to expand into other markets, other modalities, so we're really putting some infrastructure behind it. But at first, quite honestly, it was a side-of-the-desk type of situation. So if you call to another payer and ask, hey, who can I talk to about a bundle, you might not get a clear answer. Well, where are you located? They'll start going regionally on you. Well, the contract consultant for that region is so-and-so, and send you there. So just know that there might not be any program management type resources in some of these payers. The other piece to that is they might be in a market where a bundle's not necessarily a top priority. Blue Cross of Alabama is probably the one I'll specifically mention where they've kind of got off-the-shelf contracting, really. It's a totally different dynamic. I'm not an expert on the Alabama market, but when we talk to them about bundles, well, that seems like a lot of work. I don't think we really need that right now. We're doing fine with what we've got. So strategically, it just didn't align for them. So that's another piece to that. From a system limitation standpoint, and I think once, even after we got the contract signed, that was probably the biggest challenge. I think one of the bullets up here, where it was, was that we have a fee-for-service system, right? Our claim systems are all still fee-for-service. So we kind of had to figure out a way to make a bundle 90-day spend payment on a fee-for-service model. So we really kind of had to trick it. That involved separate MPI numbers. So you're filing a separate MPI number to our systems for the bundle payment. You're coordinating those downstream claims, right? So your PT claims, your home health claims, all of that downstream work post-surgery, still coming in under those clone MPIs. That's a coordination effort, whether it's going to be a convener, a central person that's billing it, or whether it's going to be those separate practices. There's still a lot of admin lift there. So that is another large challenge, and honestly, it's still a challenge today. So if you go to another payer, that system limitation is always going to be there, I think. So if I had to talk about a few things that will make this successful and really what we learned, the right partners are really the key. We're lucky that, honestly, in this room today, our two most successful and best partners for bundles are here today. And while we're going through all of those system limitations, all of those resource efforts, all of the data efforts that we're improving on but still have a long way to go, it doesn't work unless there's a viable and dedicated provider partner on the other end managing the program. The other piece that I'll mention is that from a regional standpoint, every market's different. So one of the things we really learned quickly in our experience with this contract is that if we tried to take one market agreement and plug it into another, it didn't work. It's not a plug and play type of arrangement. So you really have to get in there, understand the partners, understand the relationships that exist in that particular market with your facilities, with anesthesia, with PT, understand what the overall costs in that market are, what the members' experiences currently are, and then start learning about what program fits that market best. So I think Jake talked a good bit about kind of speed to market when we're looking to expand, and that's really the reason why, is building those relationships, understanding the dynamics of those specific markets, and then start applying and negotiating off of that. So it really is about a 6 to 9 month process when you're looking at a new market. And this is when we're still talking knees and hips. We know what we're doing now as far as payment and systems and so forth in that modality. But still, when you go to a new market, it's something that you have to consider in understanding those relationships. So if you're looking at doing an OBGYN bundle or a spine bundle or something different, that might add a couple months to the process, just from the standpoint of we've got to understand exactly what those costs are, what those different market environments are, and go from there. Right. Dr. Forrest?
Yeah, so this was just the slide for Forrest. Forrest works at Brooks Pierce downtown as statewide legal group, and he's been a fantastic partner for us. And the first question we asked 3 years ago was, is this legal? Is it legal for the doctors to take the money of the bundle, be the bundle holder, be the convener, whatever? Long story short, totally legal, but it requires a legal framework, and so we have a lot of those arrows, a lot of those contracts, and so, part of our role as a consultant, I guess, as Valere, is to just share that with you and what that would look like in your community, and Forrest would be a resource for that. So anybody who is going down that road, just let us know, and we'll put Forrest in touch with your attorney, or he works all across the state through Brooks Pierce, so he's happy to help you. I think Frank. Yep.
All right, so I'm going to talk about risk. So the entire paradigm here on a bundle exists based upon the premise of, as a surgeon, as a physician, if you're going to be assuming the risk, which you are, in return, you're going to be earning the reward. And I really have to emphasize the word earning, because it's not simple. There's a lot more work that goes into caring for these patients, as we demonstrated, and a lot of work you actually have to put in metric-wise in order to get to the point where you've earned the value-based reward at the end. So in mitigating risk, there are certain, I don't even need the slides on this. In mitigating risk, there are certain things you need to take into account even before you set up the program, and then even before you touch a patient. So there are three key things. Number one is education. You have to educate the patient and their family members. You're educating them with your face-to-face conversation as a physician, face-to-face and over the phone with your case manager, face-to-face with your PA, handouts about what it's going to be like day of surgery and what it's going to be like afterwards. And also, we have created a video about what their experience is going to be like at the surgical center and immediately afterwards. But it goes beyond just educating the patient and family member. You have to educate the staff at the surgical center. You have to educate the people in the operating room, post-operatively. And we spoke about it earlier. Very important to, if you're going to be assuming risk, to educate your partners and tell them not to press the easy button if they get a phone call. Don't send that patient to the emergency room. So that's the education part. Surgeon selection is very important to ensure that you're just going to have surgeons that are proficient and efficient in doing total hips and total knees and shoulders. You don't want your person that's out there doing one or two of them here and there. You have to have criteria, and Dr. Rowan discussed that criteria as to who we'd include in this program. And then also patient selection criteria. We've got our patient stratification tool. You have to have the right patients to do this. And if you select the right patients, select the right surgeons, educate them correctly, then you're well on your way to mitigating your risk. So then it gets to, day of and afterwards, what do you do to mitigate your risk then? Well, the key to that is your case manager interactions. The case managers are micromanaging these patients. Every little thing, the patients have a direct conduit to you through the case manager. So all that goes well. Now, what else can you do to mitigate your risk from a contract standpoint? Well, we've negotiated in our contracts number one, it's only orthopedic only complications are included. Unlike BPCI, where if they have a cataract at day 89, that's included, we're including only orthopedic complications. And if you run into a big complication like an infection, you negotiate a cap on there, 2 times the amount of the bundle. And if it goes over that, it goes back to a fee-for-service model. So what else can you do? There's a couple other risk models that we're involved in. You can get per bundle risk protection, which for a fee, you have backside protection for any kind of complication. So the third party will pay for any complication, and you've essentially eliminated your risk that way for a per bundle protection. And then there's captive insurance. Well, if doing a total joint is a 200 level course, learning and managing bundle is a 400 level course, captive insurance is a master's thesis. So it is extremely complicated, extremely complex. We just mention it up here as something that you can eventually evolve into, but it is definitely not something that you're going to start out with. It's you're essentially creating your own insurance company that insures all of your risk, and it's not something that you can start with. It's something you eventually could evolve into later on. But basically, those are the ways to mitigate your risk and to potentially make your program even more successful. Donna, you're up.
Okay, now the fun stuff. I actually have a reputation of being the buzzkill in the room, so I apologize for that right out of the gate, just because the whole business side of this got a little bit more complicated than even I expected. When they first asked me to be part of Delta Joint Management, I honestly thought I was just going to be a glorified secretary. Come to the meetings, hear what they're talking about, and it's really involved into a lot of other things, as you'll see. So one of the first things that we had to do is, as has been mentioned, is get a legal understanding as to what's involved in all of this. First of all, one of the first questions you have to look at is who's going to be involved. What surgeons are going to be part of this? Is it part of your community? Is it going to be just your practice? If you have a multi-specialty practice, that creates some challenges for you internally to determine whether or not it's something that can be done within the realm of your current situation or whether an LLC is the best thing to do. For us, an LLC was the best choice, primarily because we were involving 3 different practices in the community, and so there was no way that we could get this to work other than by doing that. So that was one of the first things that we did, was determine that an LLC would be the best formation for us. There are lots of internal legal documents that need to take place during this, and so your attorney becomes a really good friend. We've spent a lot of time with him and a lot of money with him, but it's necessary to actually put all this in place. So from everything to starting with NDAs, member agreements, operating agreements, business insurance, there are a lot of different components just to at least to starting your LLC to make sure that you've got a lot of these things covered. From that, then you get into talking about bundle agreements, and we'll get more into the details of that, but with the payers, that becomes a challenge too. When we first formed our LLC and started Delta Joint Management, one of the first things that we needed was a consulting agreement with our ASC because we were going to build the outpatient total joint program. So that was the key component to start off with. We have now turned that into more of a management agreement to continue to manage this program now that it's in place. I'm a little ahead of myself. You have to understand that I could probably stand up here for 2 days and talk about all of this in detail, but just to give you a general overview is just to give you the complexity of the business side of things. So in addition to the payer agreements, you also have the downstream provider agreements. This was another area where it became a little bit more complicated than I expected. To have an agreement with our downstream providers I thought would be pretty easy. We'll come up with one agreement, but depending on who you're talking to, the agreement has to be specific to them. For example, you need one for your ASC, you need one for the provider group. If it involves more than one practice, we had to have one for each of the surgeon practices. We had to have one for home health, we had to have one for DME, and it all involved different language. So this took one of the longest amounts of time to come up with all of these downstream provider agreements that would include the language that we needed. In some states, your requirements have to be factored into as to how much language needs to be involved in those agreements. So for us, our attorney was just key to providing all these for us. And although he could use these as sort of a template, there needed to be different language for home health or the different parties that were going to be involved. As far as an executive leader is concerned, there's just a lot of involvement on the downstream provider side of things. First of all, I always thank these doctors for allowing me to be part of this because the clinical aspect is really key to all of this, but they needed to also be willing to understand and learn the business side of it. And it can be the side that really they just want to glaze over and not pay attention to because they've got enough to do with the patient care. But this program has required them to need to pay attention to the business side of it. I can handle a lot of this for them, but they're still involved with a lot of the key components like the downstream provider management. When you're talking about the downstream provider management, it's a coordination of relationships. A lot of this is about relationships with all of the people that are involved in the 90 days worth of care to make this a good patient experience and have good outcomes. You've got the communication of the care pathways. That involves the providers making the decisions, having the meetings, like I mentioned before, just to come up with what the proper care pathways are going to be for these patients once they are done with the surgery. You have contacts that need to be established. When we're doing these agreements, a lot of times there's one level of folks that are involved in actually making the agreements happen. Then there's the boots on the ground folks that are actually going to help implement all this. You need to know who all those people are. Payments and claims. A lot of fun. The claims process was very difficult with Blue Cross Blue Shield, trying to get an understanding as to exactly what they needed and how they needed it. I spent a lot of months trying to get the downstream providers to understand that we needed to file claims in a different way, using a unique NPI number, going over all of that type of scenario. And because one of the things that happens is you'll have a reconciliation process that takes place quarterly, is what we've got set up with Blue Cross, where you'll go through and you'll look at were claims filed properly, were there any leakage claims, anything like this. One of the things that we struggled with, though, was the downstream providers were wonderful about wanting to be involved in the program until it got to the part of the claims process. And then anytime you mention trying to change something like that, we all know that in our office worlds, that's a big deal. It was a big deal to even say, we got to stop. You can't bill a patient. You can't bill a patient, and you need to file a claim differently. So as I was going down that road and we were starting to have those conversations, I realized this is a struggle. It's a struggle, and it's turning the workflow processes of these offices upside down. And so I had to come up with another way. My way to do that was to say, I'm going to file those claims for you. We will establish a way to do that. We'll figure out how to get all the right numbers on it that Blue Cross needs, and we'll put that in place, and I will take that from you. Well, of course, they were thrilled. But for them to even stop having those claims go in automatically was then still a process. So still to date, we have a reconciliation process where I get reports from Blue Cross Blue Shield that show me claims that were filed incorrectly. What that means is there's a big concern about duplicate claims submission and what is the process going to be when that happens. So that was another thing that we had to work through. What we've done with Blue Cross is we've developed a system now that if I see that anesthesia sent in a claim, they weren't supposed to, but it happened, they processed it as fee-for-service, and I've paid them too, we had to figure out what was going to be the process there. The way we've got it worked with Blue Cross right now is what they will do is once I file that corrected claim or they've received the claim with the bundle, then they will request a refund from the anesthesia group or whoever has done that. So it took us a long time to work through that process as well. With some of the other payers, they've worked out things internally that the claims process really doesn't have to change as much as it needed to with Blue Cross. But what I learned with the payers is that we need to have the ability to try and be flexible with them. They want to get started in these programs. It's really a challenge for them. So what can I do to even provide some kind of bridge, even if it's a manual process for me, so that we can begin it, because it's the best thing for our patients. And so it's been a challenge to work together, but it's also been a very educational experience to do that as well. We've come a long way in getting that information streamlined, but it's really been an effective process, and we're finding that we're really kind of getting that to work. With some of the other payers, they're able to put other edits in place so that the claims process doesn't have to change. But what I've learned with every single one of these is that every single one is different. There are different components to the bundle. There are different ways that the payer needs it to happen, and you've got to be able to be flexible with that. So payer coordination from contacts there, just like downstream providers with your payers, you've got the high-level people that are going to be involved in getting the contract set up, and between Keith and Jake, we do that part, but then I've got to work with the claims folks. How do we process those claims? So it takes a team of their people too. And there aren't many of them. There aren't many of them that know how to do this, and we can't just have people calling in to Blue Cross to ask questions about a bundle, because not everyone's been educated yet. So there are a very limited amount of people that can be your contacts there as well. The agreements that go on with them, as we've talked about, the payment pathways, how's that going to work? Who's going to receive the bundle money? How is the trigger claim or the payment claim going to be submitted? What are your requirements as far as the claims? Do there need to be unique numbers on those claims when we send them in? From a downstream provider payment method, when that money comes in, I have a lot of people to pay. I needed to have some kind of resource to do that. Same thing with the claims pathway, as I've talked about. and then the reconciliation reports, just so that we can go back and evaluate. Now, part of what happens with the reconciliation reports is we look at that and we look at the claims data that came in, and then we have to do some detective work. For example, if they show me, if I can see that there's a claim that was from an ED, I want to find out at what point did the patient go to the ED? What was it for? Was it orthopedic related? Was it not orthopedic related? If it was orthopedic related, then what was it for? If I can find that there's a claim for an ultrasound, then maybe it was a DVT. You know, looking for things like that and doing some investigation work on that side. So the whole reconciliation report side of things is even a challenge. But at that same, in that same process, we've been able to work out certain types of guidelines that we need for that. Was it truly an orthopedic complication? Is it something that Delta truly owes for something that happened with the patient that we weren't aware of? If they had an urgent care visit, what was that for? If it was for sinusitis, then it's not something that we need to take care of. But it involves looking at all the claims that came in for the patient during that time. Outcomes. That's another thing that is very important to the payer, but I will tell you, they can say it's very important to them, but when you say, okay, what kind of outcomes data do you need? Sometimes that's very difficult for them to define. They just know they need it. So when we are doing this, part of the other things that we're doing is we're having other conversations about, well, what's important to you? And here, so that we're able to share, well, here's what we're gathering. And they say, well, that pretty much makes sense. So maybe that's what we can use, and maybe we don't have to look at really what their flexion extension information is if you can give us more of a broader picture. And so it involves more conversations of what's needed. We are also expanding out now. In my conversations with payers, the other things that I've learned is there are sometimes duplication of efforts. I'm on a bandwagon right now to say, if we're going to risk stratify these patients, do we have to go through a pre-cert process? Do we have to get it authorized? For some of the payers, that's the way they trigger that this is a bundle. So it might be necessary to even just give them information, but if we're using a tool and we're making a clinical decision about the patient, we'd like to ask for some trust that we just go ahead and have that patient taken care of. We're starting to have those conversations. Yeah, we'll consider that. It's something that we can think about. The other thing that we're looking at is a lot of payers are doing some type of case management or care coordination as well. Well, maybe that's a way that we can look at potential savings in the future. If we've got it built into our program, is there another duplication of efforts there that we can work through? In the meantime, there's communication between those folks as well. So the financial management piece of this. This is what kind of led us to looking at the development of the Valere Care tool. When I got into this, it was Excel spreadsheets, QuickBooks, trying to figure out how I'm going to pay these folks. And we searched for a long time to try and find a company that could help me with this. Not only did I need to worry about the claim side of things, but the payments to all the downstream providers. How I was going to manage that, how I was going to have the reporting for that to monitor all of those payments, what our spends were in different areas. I'd been in the BPCI world. I knew the reports that we were getting back as far as what our spends were, and I wanted to be able to create the same type of information. Important not only from a clinical side of things, but just for us to know about how much we were spending on the care of our patients and to be able to break that down. So in my search for something like that, we interviewed a lot of companies. The doctors were involved with that too, just to see what type of information we could do. And we just didn't find a solution that was going to work well for us. We thought we had found a company. They were doing a lot of work on the payer side of things. They were doing excellent and very necessary work on the payer side of things. But the provider side and looking at the payment adjudication and the claims adjudication piece was very difficult. So they chose to go in another lane. And so I quickly learned that for me to have a tool, I wasn't finding anything. And I was really, as the volume of all of these happened, I was going to need some kind of system in place. So one of the things that became very clear to me is I kept hearing on the doctor side of things about efficiencies and standardization. And those are keywords and buzzwords that they were using, and I was like, I got to have the same thing over here. Every single bundle's different. Every single payer's different as to what they need, but I got to be able to be flexible, and I got to be able to manage that. So that's what led us down the road of creating a solution. Now, originally, this solution was just really for Delta. I needed something because it was getting bigger than I wanted to be able to handle. So it was during that time and realizing that there were so many parts and pieces to it that I wanted some actual tools to help me with the payment adjudication side of things. We tried to do like electronic fund transfer to the downstream providers, but they needed an EOB. And what they wound up coming back to me and saying is, can you just write us a check and send us like an EOB type document so we can kind of put this together? And I was like, so they were asking for more simplification just in how we were handling payments. So I pulled it all back in, created a different methodology, but also said, I've got to create a tool. So fortunately, that's when, between all of the complications with the claims adjudication side of everything too, and me trying to manage that as well, it just became a piece that I knew that we had to look at something else that we could build that would not only load these contracts for me, load a CPT code of a total knee, all of the prices that we break down once we get that bundle amount. There's all of the breakdown that has to happen for each one of the costs, that the payments that need to go to these folks, and then how I could manage that. So that's where, in coming up with, oh my gosh, I don't need to be near a microphone. I need to stop using my hands. With all of these different components to it, that's why we kind of created a tool with Valere Care, which you'll see that it's got the risk stratification tool and the care management tool, and there are a lot of those types of tools out there, but what is missing is the way to handle the payments and the claims, and that's the piece that I needed to create. So that's what we've been working on. It's a slow process. It's a recipe. Delta is really my laboratory for a lot of the different things and allowing me to become flexible and create more just different components in Valere. And so Mark has been wonderful to work with me on that. We've involved everyone. There's case managers that have bi-weekly meetings with Mark to come up with the solutions that we've got. I meet with him constantly because we're always trying to tweak it. I'm involving people here that have been doing some of their own bundles kind of the same way that I've been doing it and saying, look at this product that I'm trying to do. Would this work for you? And wanting feedback, just because I need to know every situation is going to be a little bit different, but it's great that I've got a team of people that are able to build something, as well as to have the payer relationships that are allowing me to have conversations with them to work through the processes or tell them what I've learned from other payers about how they're doing something to try and get them to the finish line faster. Because it is a long process. To hear 6 to 9 months now, that's great. Do I think that's really true? We've been working on some of these for a year plus, almost 2 years, and we're getting there. It's just not nearly as fast as we want it to be. Thank you.
Thank you, Donna. Welcome, everybody. My name is Mark McDonald. My primary responsibility within Valere is really building the informatics platform. So I've been working a lot with Donna, as she mentioned, the case managers. It's really building a system that's based on user feedback from the claims perspective, financial perspective, and case management perspective. So can you hear me okay, Mike? Okay. Been really lucky in working with some very good people to build what we think is a very good program and will continue to be a good program. Basically, as you've heard so far, prospective bundle payments model really brings a lot of new challenges. And you are now responsible for managing the entire episode of care from not just a clinical patient care perspective, but from a financial perspective. So you have to maintain the health of the patient, but also the health of the financial bundle. So what is informatics? You can see here, it's really just a way to gather information. But importantly, it is imperative for your bundle. You can run a handful of bundles, probably like Donna has on a spreadsheet, but when you start to get any volume at all, you'll find out that you need to automate the process if you want to scale and grow. So what we did is we started that process, and hence Valere Care. So in terms of the components of Valere Care, we have a risk assessment tool. And what that is basically, as Dr. Rowan had showed you earlier, it's a patient inclusion-exclusion criteria. What patient is eligible for the outpatient bundle, and what type of patient. Would they be a patient type 1 or 2? Type 3s are in the inpatient. So we have, second part is case management, which Jill explained. This is really about patient care coordination. Managing the patient, the expectations, the education, and really having that concierge kind of service with the patient. You know, we need successful outcomes. Case manager is critical for that. Third part is data management. Pieces of this are clinical data. We need to find out, as you saw earlier, data how we doing on complications, readmissions, acute care visits, et cetera. And also patient-reported outcomes. We collect those pre-op and also at 90 days and 1 year. And Dr. Luzio showed some of the data earlier. You can see they were very good in terms of the who's and who's junior. And patient satisfaction as well. That's all critical. And Dr. Lucy mentioned earlier where these are some of the inputs into some of the reward system internally that you can offer. So there's a score, basically a score on how you do. The last part, and this is where the complexity comes in, to be quite honest, is the bundled administration. Not a simple process. You have to get into the weeds a lot, and there's a lot of pieces to it. Managing the contracts, that's the beginning part of it, really. That's the payer contracts, but also the downstream provider contracts. The claims administration, aligning with each of the payers. They all do it a little bit differently, so you have to get into the weeds a little bit. Payment administration, recording the payments from the payer, and then matching those all with the approval and payment processes you want to put in place internally, and successfully making those payments and making sure that every bundle is reconciled. And then payer reconciliation, making sure from a claims perspective that everything is tight and there's no leakage claims, misfiled claims, et cetera. These are all systems that we work very, very hard on, and this is really where a lot of the hard work continues to go on. So those are kind of the main components of Valere Care. There's going to be a panel discussion next, and then I'll have about a 15-minute demo, just really high level of what Valere Care is. I'll be around after that to answer any questions if any of you have that. Thank you.
Donna and Jenny and Keith. I'm missing anybody. Frank, come on up. Do we have a mic? We have one mic here. Do we have it? Where did our second mic go? Rebecca, you mind running that around for me? Where's Rebecca? You can give that. Rebecca can handle it and just hand it off as there's questions. So thanks to the presenters, and I know there's several questions. I wrote down a couple that came to my mind. Anyone have a question initially? And again, the Valere Care demo will come after the panel, so you can ask Mark and dial in there. So any questions?
Yeah, just a quick question on the negotiating contracts with your downstream providers, and including the surgery center. Do you have to go through any sort of third-party fair market value assessment, or is it just kind of an insurance contract style negotiation?
It's really a conversation, and they actually, the physicians, again, I should let you answer that, probably Dr. Lucy, because you did most of that as well.
I mean, Jenny's a partner, and we just sat down and we looked at other facility fees, and we talked about how much burden it's going to put on the facility for the amount of effort that's going to be put in. We talked about other procedures, what was the fair market value locally with her for that. She told me a number. I said, yes, ma'am, and we moved on. Other questions? So I have one for Jenny. What's been the the biggest challenge? I know it's been fun and exciting, and you've been great, and your staff is awesome. What's been the biggest challenge? Anything come to mind as a challenge?
I think educating patients has been a new and enlightening thing. We've always educated patients around their plans. They have no idea what their plan means. They make a payment for insurance and think, I owe nothing else. So we're continually educating around their benefits, and but that's even heightened more, and it's been great to have conversations around bundles now and helping patients understand the financial impact for them is so beneficial, and when they hear that they write one check and that's it and they owe nothing else for the next 90 days, they enjoy that. There has been challenges around, though, that education, getting all the offices lined up as well, getting payers lined up, that we're all talking the same talk. So I feel at times we have struggled a little bit with that around the patient side.
What about our ongoing relationship, you with the physician leaders and your staff with the program in general? Talk a little bit about what we do to kind of grow the program, communicate, et cetera.
So that's been an enjoyable piece, actually, for my team as well. It's a constant communication. The standardization has helped. We do have instances where someone could veer from that standardization, and that quickly comes to the surface, and we have direct conversations, we have meetings, and unfortunately for Dr. Rowland, who has to tweak every change, it happens a lot, but the benefit is it's really pulled the team together. There have been new relationships between the surgeons and the staff, and just that increased communication, again, all around that episode, that patient care.
So we're on version what of our order sets now? 15 in 18 months or whatever. So yeah, so listening to the staff. Donna has a comment there.
So one of the things that I'll just touch on a little bit more as far as the patient responsibility, that was a little bit of a challenge as well, because when you're starting to look at the patients, you have to look at their deductible and their co-insurance and talk to them about a much bigger number that they need to pay right out of the gate, because this is something that we collect ahead of time. Jenny and her team are the ones that are actually doing that collection. But it's very important to educate all of the staff members involved in the workflow that are going to be talking with these patients as to how to deliver that message in a very positive way. Because when you look at what their co-insurance amount would be from an inpatient stay versus looking at now an outpatient bundle amount, there's a big difference. But it still requires writing a big check and teaching them and educating them that side of things. You may get many bills for over several months, and we've had to come up with payment plan options for them, and Jenny's been wonderful as far as giving them options like care credit or other opportunities to look at doing this. But these are elective cases, and one of the things that has been a little bit of a struggle that we hope to do a little bit better is as soon as you can start having these conversations with the patients to say, this is going to look a little different on the front end, and you will be responsible for this amount. We'll recheck it when we get closer to the surgery to make sure that that's still an amount. They tend to be able to come up with it. It's just a little bit of a shocker. But the bigger win to the patient, which has been interesting for me to see, is the part that's difficult for them is if they have to make a co-payment or pay co-insurance for their PT visits. That is the harder thing for them. That is the bigger win in their eyes, is they wind up saying, you mean I won't have to pay any co-pays to go to physical therapy every time? And if they have repetitive visits, that's a lot out of their pocket. So it's all in perception and how you deliver the message to them. But so when we're looking at 90-day prospective bundles, that's what we're interested in, because that's a key component to the patient. If it's a day of surgery bundle and that's all that we're looking at doing, it doesn't involve outpatient PT, and you will see them automatically deflate when you say, no, you'll still have to pay your outpatient PT co-pays or co-insurance. That's a huge deal to them. And so it's all in learning what's important to the patient as well.
That's good. Question for Keith. Back in 2016, when we started our first of 8 or however many meetings that it was, you didn't really know your 9-day span because you really didn't have the systems in place to do it. Today, if you wanted to go to market in Wilmington or somewhere, how do you have the capability, and how long does it take to do the math? Kind of little expectation management for us.
Yeah, so honestly, we've had to kind of expand some vendor relationships to do that, because really all we have to go off is our own claims data, right? So there's no real-time clinical data that's feeding into us or anything like that. So it's really a matter of a vendor relationship where they're taking our claims data, they're aligned with our systems, and we can honestly perform an opportunity analysis. That does take a couple months to get together, because the other piece is, like what I talked about, you still need to understand where's the trigger claim coming from, who's the convener of the bundle, who's the downstream providers. We have to identify all of that and understand that before we can really run a model. So there is a lot of work that goes into it before we start running it, but yes, we do have capabilities now from an analytics standpoint where we can generate that opportunity analysis much faster.
So you do have an informatics partner of your own. That's the vendor you're speaking of.
Correct.
And it would take a couple months in the market. Fair?
Right, fair.
Excellent. And then I keep hearing the term system limitation. So we're orthopedic surgeons. We have no idea what that means. In fact, we didn't understand anything Don said, actually. So we were.
I understood everything she said.
I know. So what exactly is system limitation?
So primarily what I'm speaking of is how to execute a bundle, an APM, and a fee-for-service model. That's essentially, all of our systems are still 95% fee-for-service claims-based payment, right? So it's a matter of how do we fit the bundle concept or any APM concept within that. So, and I'll just kind of pull back the curtain a little bit from the Blue Cross systems here. So obviously you have an NPI number, you're filing your claim, you get your payment, clean claim 15 to 45 days. Some of you will probably dispute that, but and then we move on to the next claim. So for this, we really had to kind of alter how the billing was coming in and alter those fee schedules. You've got your fee schedule, a dollar amount tied to each code. Really what we did is we took the trigger claim, the one surgery code, we put the entire bundle amount on that one code. So there's one claim that comes in, professional or facility, depending on the contract, and we pay the entire bundle right out of the gate. So it's a prospective bundle payment that we'll send out. So from there, any other claims that comes in on those dedicated NPIs, we set every single other CPT code to deny as part of the bundle. So that way, anything that's controlled through those bundle NPIs will essentially roll straight into that bundle payment that we've already provided. So it's a little bit tricky from a claims perspective. It leads to what Donna was talking about a lot, where it's really an educational piece for those downstream providers to make sure if they're filing those claims for themselves, they've got to use the right NPI. Otherwise, if it gets out the door, it's going to pay on their regular quote-unquote fee schedule, and we've got a leakage claim. So does that help? Any further questions from those folks that understand the billing part?
Questions for Keith, Dr. King?
One of the issues we run into particularly with one of the issues we run into with Blue Cross Blue Shield was it's an association. So we're in New Hampshire, we may have Blue Cross Blue Shield in Mississippi, Connecticut, Ohio, Federal Blue Cross Blue Shield. And even though we use what they give us a specific number, it was an NPI, it's called a legacy number. Unfortunately, it didn't fit onto a HCFA 1500 form. That caused a few problems. And so when you have a designated number, unfortunately, those other Blue Cross Blue Shields didn't recognize it. It just wasn't in their systems. And so if it came through as a physician NPI, they'd look at a bill for the bundle and go, we never pay a physician this much. This will deny it automatically. What we found is it's very important to have a specific contact person
at Blue Cross Blue Shield or at a specific, whatever the insurance company is, that we can call up and say, hey, you know, we're having trouble. Can you sort of usher this through your system because you understand it better than we do? Is that something that you've set up? Do you have that kind of system where you have a specific contact person? And from the payer's point of view, how would that work?
So and again, I'll speak specifically on what Blue Cross of North Carolina does. So it's all done at the vendor level for us, not necessarily a physician level. So it's a type 2 MPI number that we assign to our bundles that's outside of any other regular claims that are filed. So the legacy number concept that you just described, and we've got something similar. I mean, if you're familiar with Blue Cross of North Carolina, you remember our 5-digit provider numbers that were proprietary in our systems. They still are there, but they map directly to the MPIs. So there's a one-to-one match. So the fact that there's a legacy number that doesn't tie to an MPI confuses me a little bit, to be quite honest, on how that's actually adjudicated. MPIs is the national identifier now. I'm not sure how they can go outside of that, to be perfectly honest. But from our standpoint, that clone MPI really segregates all other bundle, or segregates the bundle claims from the non-bundle claims, so that really all we're talking about is those problem claims. Everything else that's funneling through is pretty much taken care of and protected by that unique MPI number. Does that help?
Well, I think the issue is when there's a snafu, our person gets on the phone and it takes them 3 hours on the phone to get to somebody who really understands what's going on. Most people don't understand bundle.
Yeah.
So I think the key to making the system work for everybody is for each insurance company, to provide us with an educated human being that we can talk to, one person we can talk to, because the amount of time that our staff spends on the phone trying to go through the telephone tree and then from one person to another person to another person, and then you finally get to someone who's in management and they go, we don't really understand this.
Yeah, understood. And it took us a little while to get there, I think, but Jake and his team, Jake was here obviously yesterday, they kind of are that central team to kind of handle those issues now. You're right. If you call our customer service line, they can speak to benefits, they can speak to how the claim adjudicated by what they physically see in the system. But as far as bundle workflows, if you will, they're not going to be able to speak to that. So yeah, it's something that we coordinate together as a team.
This is actually a question for Don. How do you do it? Because I've operated on people from Tennessee, Virginia, South Carolina, Blue Cross. Have you run into that problem? I've heard about it, yeah.
Actually, Blue Cross of North Carolina has allowed out-of-state Blue Cross plans to be included. So now, federal, no. There are certain things that are carved out. But we made that decision because we had a lot of Blue Cross of Illinois, just a lot of
So
other
they
stuff.
handle it for you? They contact Blue Cross in Tennessee or Virginia?
And don't hand your mic back out, we'll talk loud. So it's handled through the normal, if you're familiar with the term, interplan program, IPP/Blue Card. Blue Card might be the term you're more used to. It's still, because of the way we structure it, where it's still, yes, it's bundled, but it's still kind of built into that fee-for-service model. It looks and acts exactly like the fee-for-service model for those IPP numbers. So you're filing the claim to us, we price it, we send it on for the benefit determinations from the member, we pay those claims, just like any other traditional quote-unquote Blue
Tennessee
Card
pays
claim.
you or Virginia pays you or South Carolina?
Yeah, and then that administrative payments happen behind the scenes, right? The one gap that we do have right now that I'll be very transparent about is our analytics for the IPP claims is not quite there yet. So as far as reconciliation for those numbers, we're not to a point where we can definitively give that data the way we do for our North Carolina commercial membership. So that's still a gap we have, but we have allowed IPP members to still bundle through the club program.
And that's one of the things in our the Valere Care piece that I needed to define. So when the case managers are doing this, I need to know if it's an out-of-state plan, just because it changes some of the work I have to do on the other side.
Now, is Blue Cross trying to develop a best practice across, all your states and with all your different models, using you guys as the benchmark, potentially?
The short answer is no. It really is, it really is kind of a plan-to-plan proposition, and we learned that together. I think that it's all about the readiness, the strategic plan of each individual plan as to what resource they want to dedicate to that. We definitely have, and honestly, it's been word of mouth more than anything. As physicians come into things like this, where they hear about bundles of, hey, seems like Blue Cross and Delta and Blue Cross and Emerge are doing some good things. Can we talk about this? So we'll get on the phone and just kind of have a discussion about what we do and how that could fit with them. So it's more or less just some ideas and information exchange that ultimately is going to come down to those individual plans about what kind of resource they want to put in. The association is monitoring all of this. There is talk about making bundles. We've got the Centers of Excellence programs and those types of distinction programs at the association level. They are looking at doing something like that for bundles and ASCs specifically. So that's something that is on the table, but I think there's a lot of work to be done before that is done at that national level.
No. Other questions? Stephanie?
It seems to me that if a patient has to pay less, it's a no-brainer. So the question to Donna and Jenny, right, is how detailed do you communicate that to the patient, and what are the obstacles? Is it really hard to figure out how much they would have to pay at the hospital, or what are the challenges there? Because I get the question very often from my patients, what is it going to cost me, period. So, how do you do that?
So I can speak a little bit from the facility level, what we do and what we recommend to patients. So when we get a posting, especially for a bundle, we quickly try to get that in the queue to get contact with that patient to go ahead and start teeing up that financial conversation with them. And as Donna mentioned, we have set up opportunities for someone who has a big deductible that's not met with a copay, that they could then space that out over 12 months interest-free for that patient. So we do have some things put in place to assist them with that. We also encourage them to reach out to their local health system and to get a quote as well on what that financial obligation would be from that side. And we always get a call back going, yes, this is where I need to be. But we pretty much start the financial conversations as soon as we get a posting. We try to quickly get on that because that's going to be the key of not getting a week-out cancellation from that patient.
But we've lost 10, 12 cases to this issue, I think. And the problem is they go to the hospital and the hospital allows them to pay it indefinitely. And we have a year arrangement. So a year to pay off their copay insurance is less than 2 to 3 years or never. It's written off by the hospital. So that we lose that, unfortunately. So it is a lot of discussion, unfortunately, as you know, but we try to capture them. I'd love for us to figure out a way that we can pay for their stuff and have our own little way to get reimbursed to keep it in the system. It would make better sense for all of us if we could keep them in this system as opposed to them falling out to the hospital because of $5,000 that you could potentially get some way to write it off. So it'd be interesting to see if we can figure out a way to help with that.
So Dr. Olin brings up a very good point. We have had some patients that have ultimately just said, I just can't come up with that money, so they have gone back to the hospital. So these are the challenges we have with going back to the payers and talking about what else can be done, whether it's looking at waiving a deductible, because so many of the plans have such a high deductible now. That's really difficult for them. On the other side of things, one of the things that we're looking at doing from a Valere standpoint, and what I know Jenny and her team does, is you run these patients through real-time eligibility and benefits screening tool, which will tell you where they are in their deductibles and things like that. Well, when they're involved in orthopedic care or any kind of care, that changes daily. if they have more claims come in, if they have their MRI claim come in, things like that. So that's why we're looking to establish maybe that as part of our service, that we'll do that piece as soon as we know that the patient wants to do the case. And then we'll check it again. So, and provide that to you so you know about having those conversations with the patient about how much they will be faced with paying. But that would be worst case scenario. And so that if other claims come through, it could be different.
Ed, question?
Yeah, I was just a little confused as to how Jenny, I guess, as the ASC provider, I mean, you're a downstream provider, how is it you're having the financial conversation? Would that not be handled through whichever practice it comes to, or Delta or Lear? How do you divide up that?
It was simply a conversation that we had early on to say, they actually are doing that with most of the surgical patients anyway. And so it was an option that they just volunteered to actually take on that responsibility.
Yeah, it's just the point is communication. We have one message. And just so you know, Stephen, what I tell my patients is you're going to meet your deductible, either venue, you're going to meet your deductible, and then you're going to have a 20% co-insurance. You can have 20% co-insurance on, a large number or 20% on a smaller number, and that's your responsibility. And then after that, there's no co-pays. Mike?
I kind of have a poll question for the surgeons, just to follow up what Matt said. We would be interested in doing what Matt said. If you have a bundle, imagine yourself having a bundle, and the patient needs to pay, right? But he can't. Rather than if it takes the bundle out and they go to the hospital, that's one part. But would you be willing to accept that financial responsibility, do the case, and then set up some type of financial payment arrangement with the patient? Okay. Thanks.
At least interested, right?
It's kind of like college, right? Kids that can't afford it, they don't have to pay as much as kids who can't afford it. And if you still make a profit, that if their financial means doesn't allow to pay that, then you can write it off.
Right.
You still do it well.
It's interesting.
Just note, let's say you're
right now.
You're doing it now as a practice, but just
the
bundle gets more granular.
requirement in the contract that you're collecting deductible and co-insurance. That's a requirement. That's an obligation via the payer contract, at least for Blue Cross. I can't speak for other payers. So if this is a concept that we're going to entertain, there needs to be a long discussion with the payer about that too.
That's good. No. Payers are back in the room. Okay.
I'm not against the concept. I'm just saying we need to have a conversation.
We got it. It's a good conversation. Tiffany and then Dr. King.
Have you had any issues with patients' plans retro-terming after a surgery for eligibility?
We haven't. The only issue that we've had is a patient who had a case done in, say, December, and then in January they had a new plan, but we're still going to care for them during that 90 days, and under the bundle arrangement, it's a little bit different in that we will be caring for them for those 90 days, regardless. We just have to make sure that that other insurance is not involved and no claims. So it involves a lot of conversations with the downstream providers and everyone involved that you can't do that. We're going to stay under this other model.
Our issue is that there's employers that don't report an employee's termination to the insurance carrier timely. So it could be 30, 60 days later, up to 12 months in Florida, where they can retro deny a claim and take back the money. And I'm just curious if that happens with the bundles.
Have not had it happen yet. But that's a very good thing to explore.
From the payers, though, is that going to be the case?
Theoretically, it absolutely could happen.
Okay, Dr.
For Service World, I see it all the time.
Dr. King and then Stephen.
Yeah, in our market, Blue Cross Blue Shield has handled this in a couple of very interesting ways that really help us. One is if we change to site of service. So if the patient has a site of service contract, they actually pay no deductible for switching from the hospital to an ASC. The second way is there's an additional piece that the employer, I guess, can add to the contract where the patient is actually, if they go to specific sites of service like our ASC, the patient is actually paid $750 for a total joint replacement to come see us. And we like that.
Right.
Yes.
That's good. Stefan?
Concepts I've definitely heard before. The challenge is system benefit configuration, can you administer those ideas? And number two, honestly, for North Carolina specifically, we have such a large ASO business, convincing those employers to adjust and to have that additional benefit or that additional expense, if you will. That's, and State Health Plan, for example, that's our largest ASO business. They're tackling that expense a different way, apparently, but, like for them, having that conversation would be a difficult one as far as.
Keith, why would that be? If they had the option of waiving the copay for their employer or employee so they could go have a bundle where they're going to save money, why is that such a difficult concept?
Yeah, I mean, it shouldn't be. I think it's probably more along the lines of really kind of showing them trend data, which we honestly don't quite have yet. I think with some of that, maybe that conversation would be easier, but on the surface, the admin to it is not worth the end result.
Gotcha.
ROI is just not there.
Gotcha.
Anything done at an ASC is going to be like 40% cheaper.
All side of service,
This almost
yes.
sounds like enough brainer on you right now, but I don't care what the procedure is. They're all 30 or 40% cheaper, so, give the patient 10% of what they save. That's the end of the discussion of it.
Yeah. It's going to be interesting to see where we go. Stefan, you had a question?
Yeah, doing a bundle in December, isn't that a huge benefit to the patient because they're a physical therapist for 3 months, which will be January, February, possibly March, where the deductible then resets, and if it's in a fee-for-service world, they would have to pay a lot more for that PT than if they're under the bundle. Is that, am I
Absolutely.
correct?
You got it. Yeah, I haven't thought about it, but that's right. Other questions before? Good dialogue. Okay, so what we'll do next, we're winding down here. Mark is going to demo the Valere Care product, and then we're going to break for lunch for about 30 minutes, and then we're going to come back, and don't leave early. We're going to actually flip it. We're going to have a physician panel, so we're going to have a couple of our physicians, not Valere Delta Greensboro physicians, but others, and practice manager come up, and we have some questions and hear some insights from them as they've been trying to do the same thing we've been doing and some lessons that they've learned. So Mark's going to do a demo. We'll break for lunch after that. We'll come back. We're going to have a payer panel. A physician / practice manager panel, and then we'll be done. Couple points. So lunch is out here in the hallway as usual, where the food usually is. Come back in. Encourage you to continue to connect with one another. And also, again, on the little cards there that say proximity, have a pencil. If you have any input on next year or things we've done well or not well or whatever, just write them down, give them to Don or myself or one of the docs, and we're happy to look at it. I can tell you already, next year we're going to do case management track. We're going to do a CEO / practice manager track, and we'll do a physician track. The CEO practice management track will have some speed dating with our payers. The physician track will have some corroboration of ideas of best practices clinically. The case management track will have corroboration of ways to care for the patient. So that'll be a good launch for next year. We'll do it same time, same place, but those are 3 things that we'll add next year. So, Mark?
Okay, so this will just take about 15 minutes, and then any offline discussion, happy to have it afterwards. If for some of you it might be too much detail, for others not enough, so I understand that. But this will be a really quick kind of 50,000-foot view of kind of what we do. So Valere Care is kind of made into two components. The first one, can you hear me okay?
Just keep the mic close.
Okay, that better? Okay, so first part of Valere Care is kind of the care management piece. And that's really, this is what the case manager uses on a daily basis. So Jill and Renee and Lisa back there use this daily. And it really is taking care of the patient. It's that concierge touch in communicating with the patient. So as you go through care management, the first step, as you heard earlier, is basically you're doing some risk stratification. So step one is let's enter in some data and see if this patient qualifies for the bundle. So we go through a series of questions, which I know Dr. Rowan has worked a lot on in terms of whether this patient is eligible for outpatient. So some of it is kind of just basically, do they have the arrangements in place at home to be successful once they're released? And others are kind of like hard stops. You know, if some of these things are occurring, they are not eligible for the bundle. There's a third component down here as well, where there's a series of questions around, yeah, they have something, but they need, if they have proper medical clearance, then they will be accepted into the bundle. So all this is done up front prior to them being accepted into the bundle. If they are indeed accepted into this bundle, then it initiates the bundle where you create it. And there you'll select the procedure that you're starting the bundle on, enter in all the subscriber information, payer information, and here you're going to associate any stakeholders of that bundle, any providers of that bundle will be associated with this up front. So this is very important because in this system, these providers are now tied to a financial arrangement. So we're connecting all of these providers to a contract, and payments will be generated, and those payments will go through an approval process. So this is pretty standard. You go through and you create the bundle. So once the bundle is created, one of the things that happens in the background, there's a cascading group of patient calls that are created. And what you'll see, and this is kind of what the case manager would see when they come in the morning and start up their system. Well, what's due today? What kind of calls are due today? So they might have a couple of calls if you don't have a lot of procedures, or from other case managers, this may be a very, very busy day where they may have 20 or 30 calls. So everywhere in the system, it's all kind of very easily filtered, and if you're looking for any particular physician, Dr. Rogozov, let's look at a knee that he did. And I need to make a pre-op step. So in the pre-op stage, I would go ahead and make a call. And this is really the baseline for the patient. We're going to set up, well, what's the surgery date? And this is where we collect our baseline patient-reported outcomes. And the Who's and Who's Junior is what we've chosen because it's simple and very effective. It's only 6 questions or 7 questions. So we don't feel you need to go through 35 questions to get good data. And we also collect the Promise 10, pretty simple. And then you would complete that step and it would fall off your call list. So that's your baseline, the pre-op. And we've created a pathway where after pre-op, there's additional steps of discharge, 1 week, 2 week, 30-day, 90-day, and 1 year. And if I show you let me show you a 90-day call. Here, that would be your baseline after 90 days where you, during each call step, by the way, you also are going to collect any, has there been readmissions, whether they be ortho or non-ortho related, any acute care visits, if there was an ER visit, where was it, all that kind of information. It's all about collecting good data so you can have good data analytics at the end of the day. So as you go through, you're going to collect your COOs to a certain map to the pre-op. Promise 10, same thing. You're hopefully going to get improvements in all of the areas you're measuring. And at each step as well, you're going to collect any complication data. So this is the clinical complications. Again, it's about collecting good data so you can kind of wrap around, like Delta had talked about earlier. They only had one complication, so pretty easy to have a good look at that patient. Hopefully, your measurements will be as good as Delta, and it's a matter of collecting the complication and having an easy look at it. So that's basically the, let me show you one more thing. You can kind of have a quick look at the anatomy of a bundle. You know, clinically, where's this bundle at from a clinical perspective and also from a patient care perspective. So for Sandy R. Smith, we can see all of the patient details in one place, all of the bundle details as well in terms of the procedure and the surgeon, et cetera. All of the providers that are associated with that bundle. The status of the bundle from there's a bundle meter call. Details about all the steps. And then clinical notes you can collect at every bundle step along the process. They are consolidated within the bundle. I think some of the case managers, Jill, you will print this and just kind of put it in the file as well. You have the option to do that, of course. So from a clinical perspective, one of the things I realized when we were building this is simplicity is important. You know, you don't need to kind of have an incredibly complex system to have an effective system. So we kind of went on the 90-10 rule, and this is a process of continuous improvement and feedback from case managers to build this a better product as we're going along and getting more feedback from them. So we've collected a lot of data. Data is not very good if you can't see something from it. So there's another aspect in terms of just basically data analytics, looking behind the scenes and seeing how you're doing. Here's just a sample of some of the data. You can look at your anything from your gender mix to a complication rate, down to what surgeons are doing what procedures. More details about the complications. Looking at the outcomes. This will be your WHO's outcomes, which you would expect, you know, the comfort level of the patient would be low at the pre-op stage. And then 90 days later, you compare it to 90 days, and you're looking for a big gap there. And you see that pretty consistently. At 1 year, you want to get another little bump if you can. And we've seen that pretty consistently. So you are looking for anomalies. You know, it basically gives you feedback into how you're doing, not just as a group, but, you know, by surgeon as well. So this is all about improving the process, improving it clinically in any way that you can. Same idea on coups as well. We saw pretty consistent coups from pre-op to 90 days and 1 year as well. So from a patient care perspective, it's pretty simple, and it was meant to be simple. The other part, not so simple. You know, the other part is really the financial claims adjudication administration process, reconciliation process. There's more to that, as you would expect. So at the front end, when you the front end of the case management side is driven. This is kind of the engine and the levers that really push things to the case management side, from what providers and provider types you know, get displayed where, to what kind of contracts are associated with the bundle or the procedure. That's all input here. What kind of procedures that you perform and any associated contracts associated with them, your payer contracts as well. All of that is in there. So I'll give you a quick kind of use case of how something might happen in terms of how payment flow works. So first step, you would receive some money from the payer. So you would enter that receipt in, and let's just say it's for a group of 5 bundles. So you would enter that receipt, and the next thing you would do, you would match the bundles to that receipt. So if I select one of these. let me look at this one. So this is all sample data. None of this is real data. But you can see in this here case, we received a check of $150,000 from a payer, and what we've done is we've linked 5 bundles to that payment. So within that, all of the associated payments for all of those bundles are included down here. So you can search for anything within that. And within each one of these, of course, you can see the patient, the procedure, the surgeon, anything associated with any of those bundles and any of those payments, they're all linked together. You can search. You can look at, for example, where's my anesthesiology payments? There should be 5 pending payments. There's 5 bundles. I can go down, select these 5 payments, go through and bulk. It will show me the details. Am I ready to write a $10,000 check? And these are all the associated payments to Greensboro Anesthesia, which is not real. And then I would change this status to paid. I would put in an associated check number. I would put in some dates, and I would submit that. So there's a process to either approve and pay individual payments or do it as a group. You can also see kind of a quick snapshot of this payer receipt. So again, we've received $150,000. Well, what does that mean? Well, let's group each one of these providers and see, of that $150,000, who am I paying? And how much am I paying? And for what patient? This kind of consolidates it all, groups it all together, and gives you a snapshot of the financial health of that group of bundles. So you can scroll down and see all of the associated providers, and it would total each one. And at the very bottom, you see, well, how am I doing? Well, I received $150,000. I have provider payments of about $140,000. My gross profit's a bad word, but it's about $10,000. So this is money I need to take back, but I still have case management, I have administration. You know, I need to make some money on this to administer this bundle. So you want that money as high as you can without affecting patient care, but you will be able to monitor the financial health of your bundle. It's critical when you have that responsibility. It's not just the patient care responsibility anymore. You are taking that financial responsibility, so you need to be able to monitor it. What we found is you can do some bundles in a fairly manual way through a spreadsheet or something. Once you start really getting a lot of bundles, because each bundle has so many associated payments, you really need to automate the system as much as you can. So that's what we've tried to do here. And so we've talked about if you got a receipt of a bundle, you received $150,000 check, associating all those bundles with them. You can also look at a more granular level at any particular bundle. You can see how is this specific bundle doing. So this is Susan Smith, gives all the bundle details. Yes, it's been paid it's part of this here bundle receipt. And this is kind of the financial status of the bundle and what payments are still pending, what's been approved, what's been paid. And of course, all the associated providers for this particular bundle. So you're managing the financial health of the bundle at a bundle level. When you receive a receipt at a more higher level. And also, you can manage it at, really look at the complete health of all the bundles combined. So in this example here, let's just say you received this much, you paid that much, you're making about $500 a bundle, and that's just a quick kind of snapshot. And then below you can see, well, give me all of my providers, where is all my money going? And you can see the status of the payments as well. So that's a really quick, kind of 50,000 foot, this is how the back end kind of works. There's a little more to it, of course, and I'm happy to kind of explore some of the details. Some of you are really interested in this, some of you couldn't care less. that's fine. But it is important by taking on this role that you do, the financial piece of it is critical for your success. All of the stakeholders have to be successful in this, from the payers to the providers to the physicians to the ASCs. If they're all not kind of benefiting from this in some way and monitoring it, then I think we all have realized over the last day and a half it will fail eventually. So part of that is just really keeping a close eye on the money, you know. So very high level, I hope it helped some. Happy to answer any questions afterwards. Yes, if there's any questions now that you'd like to ask, I'm fine with that too.
A lot of the work that goes on here is going to have documentation like receipts and ER notes and EOBs. And those documents be embedded in that so that if someone has to come along and produce an ER note to show that it's not part of the bundle, it's put on it.
Yeah, so we're continually looking at really good ideas like that in terms of what should go where, and this is kind of a you know, full disclosure, it's like a version 1 of what we're trying to do. Attaching notes and all that kind of stuff, yeah, we've definitely heard that that's important, and it's kind of like on our list to kind of embed in this. Absolutely. Yes.
What's the cost?
So the cost. It's a really good question. In fact, it brings up another question, and I'll try to answer them both. So the cost, what we do is the administration of the bundle it's the claims adjudication, the financial adjudication, the administration of the bundle, and the software. We are proposing $1,000 per bundle price to use this. So the way we see it working is that you get the case manager uses the case management piece. We administer this piece. We see this piece as, we don't really want you all hiring financial administrators to manage this. So we see this as us playing the role of kind of outsourcing the financial administration, not the control, just administrating the bundle. And we think that's a huge value to you, where you don't have to train more staff, hire more people. You have all of the data at your fingertips. You just don't want people who don't know what they're doing to kind of mess up stuff. You want really trained people to know how they're doing this. So we think it's a big value add that's part of that cost. Yes?
How would you really do it without something like this? It seems to me a huge task.
Yeah, Donna tried, and she can probably speak to that. And she's got a lot of spreadsheets.
It's nice to have things and must have things. It seems like it's a must have thing.
Yeah, we feel that way too.
It was okay for me to handle it when we first got started with the unis and things like that, and big spreadsheet and looking at managing all of this, but it became clear very quickly that I was going to need some kind of tool that helped, because there's as you can see, there's a lot of components to this side.
Some of us have already data collection tools. They're out there, Carousel, Pulse, and Overt. Is there any way to turn on certain aspects of the software and leave the other aspects to what you're already doing, or how would
that's
a
really good question, and it's a question we're exploring as we speak. You know, full disclosure, we realize the care management piece of this. I mean, it gets the job done. There's care management pieces out there that are better than this. We're not trying to compete in that space. Mm-hmm. Our core competency is this, what you see up there. That's what we do well, really well. The care coordination piece, we are looking at where it makes sense for us to extend our product possibly into other products like that, you know, that are more sophisticated. Some people don't want or care about the extra sophistication. Some people do. So we're continuing to kind of work on version 2, version 3 of giving our customers as many options as they can for that kind of flexibility.
Just out of curiosity, Signature provides a system.
Care Mosaic, yeah.
How does this compare? I'm not familiar with it.
Well, that's a good question. We've looked at Care Mosaic a lot, and I think it might be a good question for one of the case managers to answer, but I know the feedback I heard was there's a lot to it, and it's not that easy to get around in, but there's 3 case managers right behind you that maybe if one of them would like to step in on that. Sorry, Jill.
I mean, it is, just like you said, it gets the job done. Kara's, I mean, they're both sort of tickler systems for the case managers.
And so as far as for us, it works just fine. You know, there are some things we're working on and that are going to come later, and that'll be great, like pushing out the who's and who's and the promises. I'm constantly preaching that to him. So that's going to be great. But yeah, it works great for us.
One of the things that we did was we gave the case managers an opportunity to look at other products as we were doing this, and as well as what we were trying to build for them too. We wanted them engaged that they have to use it. For me, I needed their information in my system, in what I needed, so I needed that cross communication. So we showed it to them. They agreed that there were good points and bad points to each system and everything that we looked at, but we let them make the decision as to which one would work. Ultimately, the gain for me was the financial piece that I was creating on this side of things, but I needed them to check off the fact that the case management side was going to work as well. It helps to have a blended tool. It just helps for my side of it. But we let them make the decision, and they said this would work. So it was kind of a group decision on that as well.
So if you didn't want to use the case management capability of this at all, use different software, how much additional data entry overlap would there be if you just use the financial piece of this?
Yeah, so when we create the bundle here, and this is why we built the case management piece of this, that's where you enter all of the provider information, and the provider information is linked to the contracts. So there would have to be a slight integration to use an existing tool. And we're actually looking at that right now for how easy that would be for customers who may want to do that. So it is something we're actively looking at. But basically, it's all about collecting all the provider information. That's not something that is currently done in a lot of the care management tools.
And something to bear in mind, the value equation, it's outcomes over cost. This tool includes outcomes and cost.
Yeah.
Other tools do not.
Yeah, true.
What was that, Mark?
Oh, Dr. Rowan was just saying the tool, the coordination of the tool between the care management and financial management includes the outcomes and the cost, you know. And so it's not just about measuring outcomes anymore. It wasn't a field fee-for-service world and BPCI and whatnot, but this here is really, you want to see how you're doing, not just on the outcome side, but on the cost side. So that's the value. You're getting.
It answers the value equation Steve started out the program.
Mm-hmm.
Yeah, I want to add one thing about the administration piece. We're trying to figure out, as an organization, as your bundle, as these contracts start rolling in, how can we most effectively manage them? We're finding that us being the administrator makes the most sense because we can keep it internal and we can do it well. We can automate, we can standardize, we can do the things that companies that are going to scale need to do to scale efficiently and effectively. If we allow everyone to play into the system, then we have to create a whole different type company that's a lot more expensive. And our goal here is to have you guys be self-convened, and we're just the admin function, and then we all coordinate to get that. We use your input. Mark's got the ability to create this and into a self-improvement process. So that's kind of our vision and our goal to support you as you drive more contracts, create unique product types. And if we have a really tight system internally, we can manage them effectively, then it really cuts your costs from having to stress your internal systems, but it also allows us to get very proficient and do it really well. It's kind of our thought process. And that's where the fee is. It's the whole entire package, and then hopefully we can drive cost out of that.
One last thing is, you get to a client app in your office, in our office, and then the data is on your server or cloud or whatever.
It's on the cloud, yeah. Yeah. Yep.
It's AWS and Amazon Web Services.
It's actually Google Cloud Services, sorry. Yeah, but which, as you know, is more safe than anything ever was in any company, so. Great, thanks all so much.
So one last point on that, just from a surgeon perspective. You know, the case management tools are a dime a dozen, and so we don't claim it to be, you know, necessarily better than, I mean, there is a bunch of case management tools, and a lot of them are free. The cool thing about Valere Care, because we built it, was when a case manager builds the bundle and clicks on the button for physical therapy at Joe's Physical Therapy Shop, it's tied to a contract and a payment in the background. So that's why it works. So I don't think you could just take any old case management on the top side, take our adjudication piece on the back side and work. It wouldn't work at all, because the clinical side is tied to the adjudication side. I think Stefan's point's well taken, though, that if he's already using a different outcomes measurement tool, that instead of the HUS or KUS, to embed that or add that in as an option instead of KUS Junior, if you like, some other thing that he's collecting, then that's not tied to an adjudication piece. It's just a clinical outcomes measurement.
Although, bear in mind, if you look at AJRR, they want KUS Junior either promise or global. That's what it shows.
Yeah. Yeah. And price point's $1,000. The goal there was to really have looked at how low can we keep our cost and actually still run a company. Because, you know, the option is to go to Signature, as you mentioned, and for them to take 35% of your profit. We want 0% of your profit. We want you to pay us per bundle for the service that we give you, and then you keep all the money. And that's a grand departure from the convening market. So I call us the anti-conveners. We want you to be just an administrator of it, so you can keep all the money, all the profit. All right, so we're going to break for lunch. Food is out there. We'll be back start at in about 20 minutes, about 10 till, and we'll have a panel discussion, and then we will close for the day. All right, you can keep eating, and we're going to have another little panel discussion before we finish our time together. If I could have Dr. King, Dr. Kreutzer, Dr. Zarzor, and Tiffany come up. And Donna or Rebecca would need some mics somewhere. There's one, Frank, if you don't mind grabbing that. So, just some brief introductions. Where's Dr. King? I don't think he left. Oh, there you are. You're finishing lunch. You mind coming up and joining us? I didn't give them questions that I was going to ask or anything, but I'm just going to ask them a few questions about their experience, because we have met these folks before. They've either come here to Greensboro, or we did one other little mini summit at ACUS, and I think their perspective is important. I mean, our experience is what our experience has been, and you've heard it, but we're excited to learn from others, and we realize that we're not the experts on all of these things, and so really one of our key components to growth is just learning and listening. So I want to start, I guess I'll start here with Tiffany. Tiffany's a practice manager at Fort Myers. She was here a year ago with 2 or 3 of her physicians. So just explain kind of the lay of the land there in Fort Myers, kind of similar to Greensboro in certain ways, but just explain what you got going there.
Sure, we're dominated by one major health system, so 3 or 4 different hospitals, but one system. So the physicians have definitely been trying to transition most of our care to an outpatient. Our surgeons do own an ASC, so it made it a little bit easier. We are doing some total joints there now, and most unis are being done at the ASC, so we feel like we have most things in place to do the transition, except for our biggest struggle has been the payers and being able to get agreements in place with them. Otherwise, it would be the education of the staff and the patients as well. But we feel our biggest struggle has been with the payers and getting them to the table and being able to negotiate agreements.
And you have how many physician groups in Fort Myers that you're working with?
We have 3 physician groups and 7 surgeons, and collectively they do about 750 to 760 total joints, non-traditional Medicare, a year.
So 3 different practices similar to Greensboro. You formed a LLC because that was kind of the recipe that you heard at work for Fort Myers. Tiffany is their Donna. So following a similar pattern, But what we've run into in trying to assist them, we actually went on site and visited, which was great. It was payer contracts. And so they know the pain of that 6 to 9 months has actually been more like 12. But they're close. They're getting close with one payer, and hopefully wrapped up here shortly and can launch something. Stephen, you want to share kind of your situation in Houston?
Yeah, I'm in Houston. I was an employed physician for many years and then exited that status and started Innovative Orthopedics, and the idea was to build an outpatient total joint center. It's been a challenge, to say the least. We're supposed to open the facility in June. We are partnered with Surgical Care Affiliates that are a minority owner in the surgery center. And you know, during the process, we really got involved in the idea of doing bundles, and so we're aggressively pursuing that with the help of Valere. Seems like we're fairly close. You know, we've talked bundles with the payers ever since we started for 2 years, but we really got very much involved in it about 6 months ago. I hope that by the time we open the surgery center that we have at least 2 bundles signed up in order to do that.
Gotcha. Dr. Zarzor.
Down in Mobile, there are 6 different joint guys that are interested in pursuing this in 3 different groups. And I first heard about this concept in 2016 in my fellowship in Jackson, Mississippi, and I immediately wanted to learn more. And I called Frank Lucio immediately. He was like, "When can we come up?" And he's like, "Well, we're not really ready yet." I was like, "What's the first day we can come up and learn more?" And so we came up, and our struggle is certainly payer contracts. There are 41 states that are performing outpatient joint replacement. Alabama is not one of them. We have a surgery center. It's beautiful, 4 rooms. It could easily do a joint replacement today or tomorrow, but we need some approval from a number of different authorities. But there is some hope. There's some new leadership in some big positions in our large payers in our state. We're dominated by Blue Cross. It's one of the worst monopolies in the union. Us and Arkansas, I think, are tied for the worst. But we are hopeful that with the new leadership at Blue Cross, I have a phone call in a few hours today. It's supposed to be an update on the proposal I sent to them. They at least asked for a proposal. But we're excited and understand that this is, I think the biggest realization I've had in the last few months is it seemed like bundles were the future. I don't think they're the future, I think they're the present. And it's really starting to become obvious to all involved. And because of the struggles with payers, we're thinking of outside the box ideas on how to get the payers to come to the table. And the most, I think, effective way is approaching self-insured companies to call their company that gives them their insurance, most Blue Cross, and say, do we need to switch in order to be able to save this money? Because it seems like the rest of the country is starting to do this. We want this to be offered increased quality and lower cost and lower complications to our patients.
Good. Dr. King?
I'm from New Hampshire. I've been in solo practice for about 16 years after being with the group. I'm lucky to have someone who doubles as an administrator, plus a physician assistant, Kathleen Levitt. And so we've been working on, first of all, day surgery, as was suggested here, starting in the hospital. Started that about 6 years ago, getting down to 1 day. 4 years ago, started with day surgery, total joints in the hospital, all comers, age 45 to 89, and became comfortable with that, learned who would strike out. If we planned to have 90% of our patients go home, we learned which ones were going to strike out, got some experience with that. Started doing contract negotiations with the insurance company. In our state, we basically have probably 3 insurance companies. There's Anthem, there's a local Harvard Community Health Plan, and then there's Cigna, and then a bunch of others. But we started contract negotiations, and it took me 2 years to go through all of the things that were spoken about today, to finally get, and it's a pilot program. There's only one other person in the state doing it. I've done about 100 bundled payment cases over the last a little more than a year. and it's the best thing I ever did. We now have I started the same thing with Harvard Community Health Plan. Took me 2 years to get a contract. We now have a contract with Harvard Community Health Plan, and administratively, well, in terms of the medicine, I would echo everything that this group has said. It's been a great experience. I think the patients certainly get much better care. We're paying much more attention to the whole process for 90 days and more. The patient satisfaction survey that we use is a very simple one. It's called a report card. It's basically saying, how do we do? Would you recommend us to somebody else? And it's off the charts compared to all of the other evaluations we'd had previously. So patients absolutely love it. And I think that's validated. I think that kind of patient-reported outcome is validated, I think, better than HOOS or COOS or all the others. It really tells you gives you a very important answer. How do we look to our patients? Are our patients happy? And they're ecstatic about it. If they've been through the system the other way, they can't believe how easy this is. They're literally in and out in a few hours. So we're only able to, obviously we can't do Medicare in an ASC. I have an ASC. We're only able to do Blue Cross Blue Shield, Total Joints, now Harvard Pilgrim. So we started this, and our patients literally come in, have their surgery, up walking, doing stairs, and most of them are out within about 5 or 6 hours. We have 100% of our patients go home from the ASC the same day. We've not had anyone need to stay over. And you know, it's energizing. It's just a great way to go. Administratively, I'm about where Donna was a while ago when she switched over to Valere. So I'm using a spreadsheet, Excel spreadsheet plus QuickBooks, and it is a lot of work. And so administratively, you need to have something that'll make this a little simpler, a little bit better. And I think I'm excited about looking at Valere and see what they're doing. But I would echo most of what has been said here. When I spoke with the group back at the AUKUS meeting, what was very interesting to me is it was an affirmation that maybe we're on the right track, because it seemed like in entirely separate silos, we came up with the almost identical programs. I didn't know anything about what they were doing, and it was very interesting for me to hear that we've come to almost all the same conclusions. I've learned a lot at this meeting, and I really appreciate all the input. Thank you.
That's good. So, question back to Tiffany, I guess. So, from an administrator standpoint, what help do you need? How can we help you as a company? This is a group of disruptors. We're all disrupting the market. We're not listening to the inpatient facilities. We're not listening to anyone else. We're just trying to do what's right for the patient and for value-based healthcare. So, how do we help you? You're in the position that Donna was in. What are there other things we can do? What's your vantage point there?
I mean, she pretty much hit it. Basically, you guys are the advocates too. You have sort of more power going to the insurance companies and the downstream providers at negotiating those agreements and getting them on board and getting them to understand. So just supporting that person in our role, listening to us, because we pretty much know what we're doing, but we learn a lot from you guys as well and need the support. And I think people take the physician a little more seriously at times than the administrator, so having you there, I think, brings a lot more power to the meetings.
Good. Stefan, same question really. What can we as disruptors in the market do to collectively bend the curve on healthcare in total joints?
I mean, the message is always the same. It's payer interaction and developing that relationship with payers. And it's been so refreshing here to see the payers here and how they responded and how they feel that this is a good value proposition and how they're pushing on their end to break down those barriers, because the value proposition is there and it shouldn't take 6 to 9 months or 12 months or 2 years to get this over the goal line. So I think that's one area. And I think that the message has to be strong that this is not just doing a total joint in an outpatient setting. This is a whole program that will actually improve patient care. You know, somebody else said it earlier, I think it was actually you, that we actually do care about our patients a lot more than anyone else, because we have to look them in the face to when they have a complication. So we care about outcome more than anyone on this planet. And so and that needs to be the message also coming across, that in this program, it's not just about cost, it is about improving patient care. And that's a strong message, and that's what, United Health, the U.S. needs in this healthcare system that's completely out of control.
That's good. Grant, same question.
This meeting is a big deal. I feel like being able to have conversations with all aspects of, the relationships and the payers and the CEOs and surgeons. This dynamic is unique, unlike anything else. And I was told a few years ago that another surgeon, he asked if I was reading about orthopedics all the time. I said yes. He said, "Are you reading about the procedures?" I said yes. He goes, "Stop. You need to start reading about business, because you're going to get screwed." And I was like, "Oh, okay." So you need an MBA now to be an orthopedic surgeon, it seems like. And but if you don't have a meeting like this to come to and learn just by listening so much, you really don't have a chance. And so just having this room of people assembled is a huge deal, and leading the surgeons to the light, really, on there are better ways to do this, and you don't need to become a hospital-employed physician in order to survive, is what I would like to continue to share with all my colleagues.
Dr. King, same question. What, as a group of disruptors, what do we need to do?
Absolutely continue disrupting. If you look at where the healthcare system is going, the cost, as everyone has said, is totally unsustainable. We just can't do this. If you look at where the money is going, the people actually provide the care, the surgeons, the nurses, and so forth. Our income has gone down. It's not going up. And if you look at where administration and all of the other costs are going, they're going right through the roof. The big systems, the 900-pound gorillas, have no incentive to bring costs down. All they're trying to do is grab as much money as they possibly can. This is truly disruptive, so if you think you can do it without the 900-pound gorilla paying attention and trying to squash you, I think, just as was said, you got to know something about business. But this is truly disruptive, and it's disruptive because it truly is better care. Not because we make more money, we do, but it's disruptive because the quality of the care that we're seeing and the satisfaction on the part of patients is our greatest source of referral. These patients go home, they're walking up and down the street in 2 days, no cane and no crutches after a total knee replacement. And someone says, "I thought you were going to have your surgery." And they said, "I did." Where? Where did you go? What happened? What did you do? There is something magical about going home. I don't know what it is. I can't put my finger on it. But there is something magical about a person being in their own home, not feeling sick, not feeling like they had a big procedure, good pain relief, pain control, and all of a sudden they're doing things that are unremarkable. As has been mentioned, my patients right after surgery for a couple of days, if you ask them to move their knee 2 hours after surgery, and I've got multiple videos of this because people don't believe it, they're sitting there going, "Yeah, my knee feels good." They're up walking. We want them to use a walker. We want for about 3 days, just in case they have a lightheadedness or something. But they literally up walking, no cane, no crutches, right after surgery. That's all about pain relief, not about my brilliant surgery. And so these patients go into the community and they tell people, this is different. And it truly is different. And if there's anything that motivates us as surgeons, it's seeing patients come back at 3 weeks, having accomplished in 3 weeks what normally takes 3 months. And back to work. I just operated on a gastroenterologist. He was back in the office in 3 weeks and doing endoscopy in 4 weeks. He's walking around, you can't tell what knee was done. So there is truly something that's different about this. I can't quite put my finger on it. It's probably they're more active. They're probably getting their motion better. They feel better. They're not feeling sick. They're not on narcotics. They're not nauseated. They're not having all the side effects of the these are all iatrogenic side effects. The nausea, the pain, the constipation, those are all what we do. And so the only message I would say is from a clinician's point of view, it's the best thing I ever did, and looking to expand it. And I'm, again, very interested in Valere because I think I need something like that with more than one company involved. And as we expand, I just have a new partner, And as we expand the volume and bring other surgeons on, hopefully, we're going to need more administrative help. The 900-pound gorilla doesn't like this. They're not going to be happy. But I think this is the future of medicine for us. If we're going to survive, the way to not go is to be employed by these systems who are going to pay you nothing for what you do, and they think they can provide for the patient all the pieces that we're providing with this system. They just can't. All the committees on Foley catheters, the committees on blood loss, the committee here, committee there, trying to do this in a fragmented way. It doesn't work. And the only way it works is when the surgeon's in charge, from the top down, organizing everything, seeing everything, controlling everything. And that's really how these programs work. It's all about the surgeon being in control. And I would put my 2 cents in that the money shouldn't flow to an ASC, it shouldn't flow to another convener, it needs to flow to the surgeon, because we're the ones who are responsible for 99% of the orders, for all the care, for all the cost, and we're the ones who control that, and we should be controlling the dollar, not anybody else.
That's a good word. Grant?
As far as the specific way, I'm going to leave here today all just excited and ready to go just like last year, and we're all going to be, this is going to happen and we're going to do this, and I'm going to have my call. Yeah, it depends on my call. That's what I was going to say, and then my call doesn't go well, and I go home, and I'm like, I'll go see some patients. But then I'll come to this again next year, and I'll be all excited. So if there was a way to continue the dialogue throughout the year, and I don't know if it's a listserv where we can email out where everybody's all on the listserv, and we can say, hey, I'm in Alabama, and crying and need some help. Then somebody may reply back and lift my spirits a little bit, or Sean may say, well, we're going to get that Aetna bundle. We're going to get all the Aetna people on the Panhandle coming to Mobile. I'm like, yes, here we go. Now we're good. And so if there was a way to continue the dialogue separate from just these 2 days.
That's good. That's good feedback. And we were thinking about doing a Valere Network Physicians kind of newsletter, if you will, or email, where we just highlight a pearl of wisdom and then maybe reach out for a pearl of wisdom from others, and we'll figure that out, and then how to incorporate CEOs, case managers into that. So kind of a parting comments. Thank you. Y'all just stay seated right there. You don't need to go back to your seats because we're done. But a couple parting comments. So we did not start this journey 3.5 years ago to become consultants. We started the journey 3.5 years ago because we had learned through BPCI there was a better way to control costs, and we felt that if we had partnered with commercial payers to do it, there was enough delta, enough money in the system that we could design a program that would create a win for all parties. And we did it. And we've done it 359 times. And so we're privileged to be at the tip of the spear in that regard. And so then we said, well, you know what, we want to help our patients. We did that, and we want to help our colleagues. So really, as a consultant, it's really we're surgeons who are colleagues, and the default was, or the necessary things that came out of that was a Valere, which, by the way, is the Latin word for value, and then a product. Neither of those things were things we set out to do, but that's who we are. So really, our heartbeat is for our surgeons, well, for our patients and our surgeons, and the product. I mean, I'm a terrible salesperson. It's a great product, and it's as cheap as we could possibly do it. I think we're actually underselling it, to be honest with you, because we've now added we said we would tickle the buttons and pay everybody. It was $1,000 before we made the decision to be your little financial button pushers. So we should have gone up on the price, and we didn't. So we can argue about that. I'll argue about that with my partners. But anyway, we're trying to keep your costs down so you can convene, so you don't have to hire some outside industry person, take an inside industry partner, and we'll help you manage the whole situation. And so that's our heartbeat. So kind of leaving with that, what Grant said, so we're looking for ways to help patients and surgeons. And so I think a continued dialogue throughout the year is an excellent point. I think having a physician track next year where we get together as physicians and say, hey, what are you doing? What am I doing? And we talk about that, incredibly valuable. So we want to listen to you, what you want from this meeting. We want to hear feedback on, is it right? We tried to do a Thursday evening so you could work a half day and make it here, Friday morning so you can get back to your family for the weekend. So we're really trying to be thoughtful about what we do to make it work for everybody. So we really, really do appreciate you coming and joining us. It's been, Yeah, we'll be at AUKUS every year doing a symposium You can bring your partners or your administrators there. But we'll be here, same time, same place next year with a bit of an expanded agenda. Please give us your feedback. We'll even maybe send an email out, maybe with a questionnaire or something, I don't know. But it's your meeting, it's our meeting. We want to corroborate, and it's a powerful, powerful thing when we do that.
One last comment. Encourage everyone to get a book. It's called Conscious Capitalism, because it was written by John Mackey, the CEO of Whole Foods, and it's a wonderful concept. I think it's a solution to healthcare. And I think what you're doing is really focusing on what that concept talks about. So Conscious Capitalism is a great book. It's a yellow cover. It was a game changer for me.
Good. Thank you for that. Donna?
Just one other thing I'd like to say. First of all, thank you for everyone that has come to this. Every year, we just cherish your feedback and your willingness to come in and participate with us on this and learn more together. Huge thank you to Dr. Lucy. His work is tireless. It's constant. We are fortunate enough to be in the same building, down the same hallway, where we can be changing hats all day long and talking about this, but it is a huge amount of work. He's a surgeon first, as are all of the surgeons. Dr. Lucio, Dr. Olin, Dr. Rowan, they've all put in a lot of hours to try and make this happen. So even on the administrative side of things, they've been so supportive to me, allowed us to think about creating Valere, involving Mike and Mark to help us build a tool that will be good for everybody. It's just been really great. But also thank you to the case managers for being a part of this, and all of their input too, because it really takes a team to make all this work. In addition to that, one person that we have not introduced yet is Rebecca Rogers. She joined us in January, and we had her at office with us, and she complains that it was a 4-month interview for getting to know everything that we're doing and trying to understand it. And she's been in the healthcare management world for a while. So you've probably had emails from her, and she is involved as kind of account manager for us now. And she's been a great help to me as far as trying to learn this. So I think she will even agree that this is, although it's very fun and exciting, it's a lot of tough work. So I appreciate her as well. So thank you very much.
All right, you are dismissed, but in about 10 minutes, the North Carolina physicians have a little strategy meeting at this table. So if you're from North Carolina and you're a physician, join us here. Thank you so much for coming. Safe travels.